Good morning, everyone. Thank you so much for attending. Welcome to day 2 of Giant 2020. I hope you all enjoyed the event yesterday. Today, we are going to be running 3 consecutive sessions from 10 a.m. to 1 p.m. We have a number of speakers who will be discussing topics related to immersive technology, for example, virtual reality, and how we'll be discussing how this fits in with the healthcare system. I would like to introduce Valentino and Denise. We have 2 speakers today in this session from 10 a.m. to 11 p.m. Valentino, could you please introduce yourself to the audience?
Yes, hello everyone. So I'm Valentino Megale. I'm a PhD in neuropharmacology, and I'm the CEO of the digital health startup Softcare Studios.
Hi, so Valentino is in Italy, and my name is Denise Silber, and I'm coming to you from Paris, France. I've been a long-term digital health communications pioneer. I created Doctors 2.0 conferences that you might have heard of. And more recently, I am the co-founder of VR for Health, which I'll be talking about in a minute.
Brilliant, thank you. So let's just open up the discussion. Let's talk about immersive technology and VR. Firstly, if you could both just explain to the audience and myself, who perhaps don't know a lot about immersive technology, what is VR?
Now, I would love to talk about the word VR, virtual reality, because there's a lot of confusion. This is a great way to begin the topic. So immersive technology is based on the idea that the user is going to be so immersed in what he or she sees, and we're going beyond seeing with what's called haptics. So through touch and even smell is coming up. They will be entirely focused on whatever it is, and different things can happen. This can go from training, so educational purposes, to therapeutics and other things. But what is happening is that there is such innovation in this area that a lot of different words are being used. And it's confusing for people who hop into this. And it looks to me, but I'm sure Valentino will have his opinion, that there is going to be a divide between what are the B2B terms and the consumer terms. So from a consumer perspective, everything is sort of virtual reality. They also think it's the same as 360 degrees, whereas it isn't. And it began, and there is also something called augmented reality, which doesn't seem to be taking on as a consumer word. Augmented reality is considered immersive. In my opinion, it's not really immersive. It's only immersive in the sense that you're forced to see it, but it doesn't grab you emotionally. The best example of that is Pokemon. When Pokemon Go came out, that is true augmented reality. You're holding an app, you're looking through your phone, and instead of seeing just what you would ordinarily see, you see words and figures pop up. And now people are, so I've already mentioned several terms, and now people are talking about XR, which is sort of the meeting of all of this. They're also talking about extended medical reality. So there's a lot of wording that is used by the experts, but for the ordinary person, I think it's just VR, virtual reality. Valentino, do you have a different take on this?
No, I definitely agree with you. I think that we should become familiar with the immersive technologies intended as a continuum of very different grades of immersion. So the really focus and core of these technologies is the ability to blend with our physical reality and add digital and virtual elements in different degrees. So we can start from a low percentage of immersion with augmented reality, with these digital assets that just add up on the physical reality, towards 100% of immersion with virtual reality, where everything we see, everything we hear is completely computer generated, and we have no connection with the physical reality. And the potential of these technologies is that they pass by our perception and sensorial engagement, and they trigger reactions in the user. And this is fundamental, because if we can trigger a reaction, we can guide the reaction of users, and we can guide these reactions towards a goal which is meaningful for a specific setting, for instance, healthcare. So that is the potential of virtual reality: guide the attitudes of users towards a more efficient and optimal goals in every settings, from the entertainment to the education to the healthcare.
I would, that was a great follow-on, Valentino, and I would add that what you were saying triggered my memory about the book I recently read, which, for your viewers who want to get a good understanding of this field, it's VRX, the virtual reality medicine book written by Dr. Brennan Spiegel, whom we've met going to his conference. And what I love about the book is that it develops a fundamental truth of virtual reality, which is that when it is used therapeutically, it can only work if the person who produced the program understands and sort of sees with total empathy through the eyes of the user, which is why I believe we will go towards more and more customized virtual reality, so that each person can have the most effective exposure. And Dr. Spiegel says that this can bring a totally new dimension to medicine. First of all, we will understand much more, and Valentino is a neuroscientist, the relation between the brain and our overall medical condition of feeling okay or not, and also what drives us to the proper behavior. But also what I just mentioned about customized use, so that it is no longer one medicine for all.
Exactly. And virtual reality offers us with the opportunity to really iterate the solution in order to better fit the real needs of the final users. This is something resulting from the use of software, and very challenging when we talk about physical and analogic environments. So this is an added value of VR and XR in general.
Of course, we haven't mentioned the disadvantages, which there is no efficacy without issues of tolerance in our world of healthcare. So there is a small percent of people who would not be able to use it. It's not at all what traditional physicians used to think, oh, old people won't be able to. On the contrary, they often seem to really throw themselves into it with more abandon than others. But there are people who, perhaps for physical reasons concerning the head and the neck, so far with the current headsets would not be able to use it. There is the question of the speed of what you're seeing. If the refresh of the visuals is not done at the proper speed, then people can experience dizziness. But overall, and I will be talking about some of the studies, there has been such fantastic results in several medical indications, which are pain, anxiety, and other central nervous system like depression, and rehabilitation or re-education, meaning learning to recreate the pathways in the brain. All of these are the principal medical uses that have so far not been stopped by concerns about the limits.
Brilliant, thank you. So in terms of, as you just said, VR is very useful in all these different types of medical fields. So let's talk about perhaps uses in cancer and research.
Well, yes, maybe this would be the point where I would explain to you the goal of my company and why I took a look at cancer. So just the origin of VR for health is that I was in a conference like this one, the Virtual Medicine Conference, hosting a panel of patients. And we all agreed, myself and the patients, that finding information about virtual reality and having it proposed to you was far too rare an event, because currently, from the healthcare provider side, it is still not only, but mostly in piloting and research stage, and the average person just wouldn't be able to go in and ask for it. So this led to a person in the audience approaching me who was a surviving cancer, very well surviving, cured cancer patient, who said, let's do something together. And I'm about to show you about that and then take the cancer example. So I'm going to open my slides. So you are seeing this talk called The Status of the Use of VR for and by Cancer Patients. And the reason I put in for and by is very important. It's usually in medicine for the patient. But in fact, when someone puts on the headset, they are in the driver's seat. They agree to look at this and they go on the experience. So vrforhealth.com is a website that we launched just a couple of months ago that symbolizes, or this is the symbol of our website, which is that you have the practitioner and the patient getting going, and the patient is explaining what is happening. This would be an introductory session, of course, but that we very much want to provide information that is of good quality, best practices for both the patients and the practitioners. So the website is divided into different sections that are all grids. In each of the grids, so for pain, anxiety and depression, rehabilitation, you have a selection of videos that present news and information about the use of virtual reality as a therapy. In fact, this term is so recent that there isn't an agreed term. Sometimes we say TVR for therapeutic virtual reality, but there is not yet a specific term for it. We also have lectures that have been given at conferences that are for professionals, but anyone can access them. And we have blog articles on interesting topics and in discussion with people who are noted in the field. So you were asking earlier about virtual reality. It can be used in a diversity of medical conditions. I'm going to speak about various ages, and Valentina will speak about pediatric, and all around the world. It is something that is really not limited, and undoubtedly, you were discussing yesterday at the conference 5G. The arrival of 5G will be a plus in terms of expanding what can be done in virtual reality. So if we were to look at virtual reality clinical research in the past 5 years, we would see that there have been a tremendous number of review articles in the areas that I mentioned: pain, anxiety, depression, and rehabilitation. A review article, as you know, is an article in which scientific healthcare professionals or scientists would select studies that bear upon this topic and try to come to a conclusion, because one study does not a conclusion make. And there's a tremendous number of review articles, but one of the limits that we would like to help with on VR for Health is the fact that the free access ones are, of course, quite fewer than the entire population of review articles. And we decided to zero in on cancer as a first topic, but it will not be our only topic, because it's very interesting that we're not saying, because it would not be the case, we're not using virtual reality to treat cancer. We're using it, we're recommending its use to help manage some of the medical issues that arise when a person has cancer. So, for example, there was an interesting article from a number of years ago, but the figures would be the same. Pain is very common in cancer patients. It's in 20 to 50%. And of course, in almost all patients, when they reach advanced or terminal cancer. And there is a terrible feedback system between pain and distress and more psychological distress. So the psychological factors play an important role in modulating the pain. And yet, what we know above all is that when cancer patients have tremendous pain, they're simply given stronger and stronger and stronger medications for the pain. And up until now, there has not been very much work done on trying to attack this situation from another angle. So I wanted to look at what is going on, and this is all coming out of the National Library of Medicine database known as PubMed, what is going on in research findings between virtual reality and cancer. So this is a first look, and we plan to put this information on our website, and what we are looking for are partners, any companies or organizations who would like to help support our work in making known that virtual reality, because it is efficient in respect to pain and anxiety and other mental health conditions, has an impact on our health by developing specific areas. So it can be cancer, it can be hypertension. There are many different areas of interest. So if we look at clinical research in cancer and virtual reality, we see that there have been already a certain number of review articles, but even fewer are in free access. So again, many people would not be able to know about them. We then looked at the ongoing trials, whether they are completed or ongoing, and we find it very interesting to note that this field is international, that only 1/3 of the trials are in the US, and the rest is around the world, and in particular in Europe. As I mentioned, I have been following digital health for since its beginning, since before the term, and this is the first time that I see a digital technology that has such a firm foot in Europe. One could say that perhaps thanks to the diversity of countries in Europe, there is more activity in terms of the number of startups than there is in the US, but at least an equal footing of activity. And I see that the academics are connecting globally. So now if we look at some of the studies that are recruiting, we can see on the right that they are recruiting again in very diverse locations: France, Korea, Oregon, and Colorado, that they are recruiting in diverse indications. So breast cancer, endometrial cancer. There's also an interesting one in virtual reality and imaging review, meaning that when the diagnosis is being done to support the patient by having them examine this in virtual reality to better understand and at the same time also perhaps benefit from the anti-anxiety aspect of it. These studies, so China, Canada, France, Denmark, US, honestly, you don't see such variety when you look at other topics. And here we have colorectal cancer, chronic pain, brain tumor, bladder, leukemia. We see young people, general adults. So really interesting. And in the will recruit, so these are even further studies, we find yet more. The locations were not yet mentioned, so I don't present them here. But you can just see the diversity if you can read this. So before chemotherapy, I believe that virtual reality during chemotherapy will have a fantastic option. We know that, and I believe that Valentina will talk about it, that in relation to the pain of the moment of an injection or entering a catheter, there are so many opportunities. So palliative care, I have discussed with palliative physicians the opportunity to bring virtual reality to hospices at the moment of diagnosis. So just a wealth of knowledge that if you take any one physician, no one would know, if I gave them a quiz with relation to cancer, all of these different things. So there has also been in 2019 a meta-analysis of the efficacy of virtual reality in symptoms management, and the result is statistically significant. Typically, in any of these analyses, the researcher always ends with saying, and we need more research, and I'm sure we do, but this is very hopeful, this kind of text saying that there is empirical support to concerning the efficacy of VR-based intervention. And I mentioned earlier Dr. Spiegel's book. He'll be happy that I'm plugging it here. This is a picture of that patient panel, and I love to keep them in mind. The first person on the left has chronic pain from war wounds, who's a veteran. The second person suffers from cerebral palsy. The third has a chronic Crohn's disease, and the fourth was a severe fracture, a sports accident. They all could not speak highly enough of how virtual reality had intervened and interrupted their misery. And that supports the phrase of, when used to correct perceptions that undermine health, VR becomes a radical new therapy to help alleviate suffering from the most intractable diseases of mind and body. And I feel emotional even just thinking about the goal of VR for health in making all this information known through videos and through blog posts and other ideas that we have for further content. So if this, speaking to the audience, whether it's the current audience or the replay audience, if you have ideas of partnership for increasing the effectiveness of the messages we want to get out about the best practices in therapeutic virtual reality, please contact me, reach out to help us. We will be delighted. So, thank you very much.
Denise, thank you so much for that presentation. That was absolutely brilliant. And I think I can say on behalf of everyone, incredibly inspiring. Thank you so much for that. I would like to ask, in terms of, as you said, connectivity with VR around the world, we have all these different countries doing research and statistical research into the efficacy of VR. So let's say in a few years, where do you hope for VR to go in terms of the future?
Well, a part of it is going to depend on the business models to reach the consumer, and also educating the professionals. So we would like to introduce educational material. That's another call for support from the Giant Health audience. So perhaps we can do an article about that. But I believe that if we can move to affordable subscriptions, because the issue is that the headsets evolve and people might get one and then they realize that the next one is much better. So if we can come up with a subscription model, I believe you will see the use of VR in our anxiety generating world for a level of wellness become very widespread. Then as to which organizations, which healthcare provider organizations will move forward. First of all, you've got all the startups in Crunchbase, you know Crunchbase, so from TechCrunch, there are a good 100 startups. So if each of them is doing studies here and there, they're introducing it to many, many hospitals and clinics. And then I believe that in the countries that have private systems and where there's competition, there will be an offering like this by the providers. And finally, if I can speak for the place where I live and that country I've adopted, there are a huge number of hospitals piloting it at the present time. There's also going to be a greater and greater use, thanks to another startup, as a digital sedational tool. Mm. So just as you might have seen in your history class how in ancient Egypt they did brain surgery and you wonder how the patient was able to stand the pain. Maybe they had methods. It looks like the use of VR for anesthesiology will spread more and more, and that can give ideas. So in 5 years, I think that'll become fairly common to see your provider offer it to you.
Amazing, thank you. Valentina, do you have anything to say from that?
Yes, I perfectly agree with Denise that the real challenge is the business model and the education of healthcare providers, because virtual reality, as I will say also in my slides, is not a pillow. It's not a digital pillow. It is a process. It is a process that promotes multi-stakeholder collaboration, but it also requires multi-stakeholder collaboration. So we need the different players of care to be engaged and understand the new tools in order to implement it efficiently in the clinical setting. So I think that all the work of startups, academics, and the institution will be fundamental to spread these new technologies and iterate the tool to very different settings in order to differentiate the case studies. Okay, people and the healthcare institution, they need new use cases. To understand, virtual reality is not only entertainment, it is for the digital sedation, we can say, it is for pain management, it is for rehabilitation, it is even to provide continuity in care now during the COVID emergency, because now healthcare is disrupted. And there are a lot of people who just cannot access to care. They just have care routines that are disrupted by social distancing, by the confinement at home. So virtual reality is something that can bring continuity and accessibility to care pathways.
Brilliant. So let's talk about, in terms of pain perception, as you were mentioning, Denise, in your presentation. So if we could just explain how finding a means of alleviating an individual or a patient's level of pain is very important to health outcome in terms of, say, perhaps getting through operations, getting through things that are very difficult for them during times, for example, when they have cancer.
Yes, I'll speak briefly about that, and I think it'll be a great segue afterwards for Valentino to present his work, which involves pain, doesn't it, as well, Valentino?
Yes.
So, yes, you have a terrible interconnection between pain and anxiety that if you are expecting to feel pain, you expect more pain and get more pain, and the pain and anxiety feed on one another. So in cancer, this is a particular problem. For example, there is an article on our site about the anxiety of having the treatment. Proton therapy centers are currently, some have it and are working on how to bring virtual reality into the center during the treatment, because these are huge rooms and it's very noisy, a little bit like getting an MRI, but maybe worse. And for example, Dr. Levin at Penn Medicine in Philadelphia placed a headset with an anti-anxiety, with a relaxation type of program, and before going in for this treatment or before going in for other exams, and the patients couldn't get enough of it. They felt so much better before going into the exam room that the entire experience was better. For chronic pain, the pain is sort of the same, whether it's of cancer. I mean, the degrees are different, but the tracks of pain that are created in your brain are the same, whatever the original cause, and they become self-fulfilling unless you can interrupt it. So that is why virtual reality is so important, because so far we believe that the brain can only take one signal at a time. At least this is what has been demonstrated by working with virtual reality and other methods. And therefore, that permanent signal of pain, think of me, gets disrupted. We call it distraction therapy, by looking and being completely captured by the program on the headset. So that is why it is of such interest. And Valentino mentioned the pandemic. There is also what we call the epidemic of the use of opioids in the US, and many departments are looking and using virtual reality as a way to reduce the consumption of these very heavy painkillers. So it goes beyond cancer, but I think it's important because there's a lot of awareness of cancer, a lot of willingness to research on cancer, and I think that it can be one area to develop virtual reality. So maybe Valentino could give us his talk at this point.
Yes, absolutely. It was definitely fundamental what you said about the competition between the virtual reality and pain perception, because that is the core of pain reduction with virtual reality. So I will just share my screen. Okay. Do you see my slides?
We do, and we see as well the talking heads.
Okay, perfect. So again, it's my pleasure today to present what we are doing at Softcare Studios. I'm the CEO at Softcare Studios, and we are using virtual reality to provide value and support to patients in the hospitals, and also to optimize the work of the medical staff. So just a very short intro. Softcare Studios is a digital health startup based in Italy. We are now active in 9 hospitals between Italy and the US in Houston, and we are undergoing 4 hospital pilots in order to show up the evidences, more evidences about the impact of our solutions in the hospitals. We're normally collaborating with medtech and pharma companies in order to facilitate also the distribution of our solutions in the hospital network. But we also collaborate with patients associations and foundations, aiming to provide solutions that are as close as possible to the real needs of patients, because there is no one standard experience of patients in the hospitals, and this experience changes from one patient to another and from one hospital to another. So understanding their experience is fundamental to bring personalized and efficient immersive solutions to them. So first of all, let's start from virtual reality. We use virtual reality because it is a digital, not invasive solution. This is a value, and at the same time, it is a deeply persuasive solution. So this is something that is able to influence and reshape the attitudes of patients toward their experience in hospitals and beyond. Virtual reality is a technology designed to simulate our presence in other places that are different from the place where we are with our physical body. And this is made possible thanks to a specific hardware interface, the VR headset, that provides the immersion into the virtual content in a way that is able to trick our senses and convince our brain it is real or realistic. And in this case, our brain really believes that it is not just a passive watcher of the content, as in a case of traditional digital screens, but we believe, and our brain believes, that we are part of the content. We are experiencing that content in first person. So thanks to virtual reality, we have the great value that just with one virtual reality headset, we can choose and experience a variety of content, a variety of experiences based on our needs and on our goals. But why experience matters? Because experience shapes our cognitive processes. This is fundamental. What we see in this image is the so-called psychomotor loop. This is the simple basis of our daily life. We receive sensorial cues from the external world. Our brain processes all these cues and generates the process that we know as perception. And after perception, all these stimuli are evaluated and compared with our past experiences in order to catch an opportunity or avoid a risk. And based on this evaluation, we just react. And there are a lot of kind of reactions, motor reactions, sensorial reactions, cognitive, emotional, cultural reactions. But these reactions allow us to survive and to optimize our life routine from one day to another. So what is important in this image is that virtual reality is a technology made for our brain, made to engage and stimulate our brain, and able to provide audio and visual cues that trigger specific reactions in the user. So we can synthesize virtual reality with this sort of equation. Okay, we expose the users to specific stimuli, we trigger specific reactions, and with the right design of the virtual reality content, we can guide those reactions toward a meaningful goal for that setting. We can just entertain, we can educate, we can facilitate the memorization of a specific content, but we can also support the healing process. So virtual reality is and can be a digital health tool, providing very important and significant value to the healing process. The applications of virtual reality in healthcare started in the early 90s with the studies of Dr. Hunter Hoffman and Peterson, who developed the first content for drug-free pain management called Nayot, that was provided to patients with multi-burns. And they showed that virtual reality is not just a distraction tool, it's definitely providing more and better distraction than traditional tool like watching a movie or playing a traditional video game. But what they saw, also thanks to the MRI test they performed to the patients undergoing this treatment, is that virtual reality is able to almost shut down or limit the activity of brain areas related to pain processing. So virtual reality is able to compete with pain stimuli. It is able to really reduce how much we feel about our physical body during therapy. Why? Because our brain just believes that our body is the virtual body, and the physical body lacks in priority in the perception process. So there are, starting from these studies, there are very different applications for VR, from rehabilitation to phobias treatment, PTSD treatment, also for the treatment of eating disorders. In our case, with software studios, we focused on stress management and education of patients. Because talking with hospitals, with medical specialists, and with patients and their families, we saw that stress levels and what patients know about therapy is fundamental to improve or not the adherence to therapy. The adherence to therapy is the extent to which patients are compliant to the prescription of the medical staff. And this is something that it impacts not only the quality of life of patients, but also the efficiency of healthcare treatments. Because a patient that is not compliant, that is not adherent to therapy, results in a waste of healthcare resources and also in longer time and higher cost of treatment. Because and it's very general, it involves younger patients, adult patients, elder patients. A lot of patients experience therapy as something bad, obviously, as something that is providing pain, anxiety, fear. So they undertake avoiding behaviors they try to avoid therapy, they try to avoid painful treatments, and this causes delays and disruption in the entire care process. So stress levels are a risk factor for pure adherence to therapy. And it often depends from what space patients perceive around them and how they spend their time during therapy. Space and time are very important things because we can reshape with virtual reality, partially, what patients see around them and how they spend their time as patients. So we started our first project, Tommy, working with pediatric patients, especially in oncology, but also in orthopedics and dentistry. Tommy is a virtual reality gaming experience because the game is and game mechanics are the natural way pediatric patients cope with their risk, with their issues, with their challenges. Tommy is designed on one side to distract children from the hospital settings, in the hospitals during the long-term hospitalization, during painful and stressful medical treatments like chemotherapy, and also blood tests related to the cancer care process. So thanks to virtual reality, thanks to the immersion in virtual reality, we are able to reduce the anxiety and the pain perception, improving the stress management in those kind of patients. But at the same time, in Tommy, we have activities that involve both patients and their caregivers. This is an important part because patients' experience during the care process is linked to the experience of their caregivers. We need to help both. We need to create connections, relations, and better communication between patients and their families in order to promote the resilience of patients during the challenging cancer process. We are now studying Tommy in different hospitals. Unfortunately, because of the COVID situation, a lot of our studies stopped for different months because of safety, of the safety emergency, obviously. But preliminary data of the pilots that we are now restarting show us that virtual reality and Tommy, as it is designed, is able to reduce pain perception in patients, especially during the so-called blood test. We are studying how Tommy can improve the experience of patients during blood test. And we use Tommy exactly during the blood test, not before and after. And thanks to Tommy, children just undergo the test. They are calm. They just do not perceive the entire treatment because they are distracted from the virtual environment. But what we saw is that virtual reality and Tommy also triggers communication between patients, the caregivers, and the nurses. Because there is not only the isolation, the physical isolation of patients that stay in the hospital. There is also a social isolation there that provides more anxiety, that provides a worse patient's experience. During the hospital experience, everyone is just living his role. Patients are patients, nurses are nurses, and families are stressed families. With Tommy, we provide a platform to create connections that go beyond these roles. So patients become players, the caregivers becomes co-players, and the nurses becomes a context of people that can talk about something that is not related to therapy. So what we saw is that nurses and doctors that normally do not talk so much beyond the treatment they are providing, they start to talk with children. They create connections with children, just talking about Tommy. And this is an emerging value of Tommy that we are now analyzing, that we are now studying in order to optimize this process with new projects. Beyond Tommy, we are also working now with adults and elders. So we are replicating this model, this approach with different kind of patients focusing not only on the instruction, but also on the education of patients, because patients that better know therapy, better know the challenges and all the details and aspects of a treatment, are patients that experience better the entire care process. They're just more empowered, and they feel control in their disrupted life. So we are, on one side, we are simulating medical procedures and showing the simulation to patients that can try a medical test, comfortably sit in their couches. But we are also building virtual scenarios where patients can meet each other. So we create and focus on social relationship between patients, because they can play, they can be challenged by game mechanics, but they can also share their experiences and their challenges with other patients that are living similar conditions. We are also experimenting with space as a healing dimension. So just imagine there are healing gardens provided by some hospitals, but some clinics to patients with neurodegenerative disease. But obviously now, accessibility and continuity of care, as I said before, because of the COVID situation, is disrupted. So we are working with some academic institutions in Italy and also with patients' foundations in order to produce a virtual replica of those healing gardens, in order to provide the value of the healing spaces to patients wherever they are, even if they cannot access the physical gardens, even if they are confined at home because of social distancing and COVID situation. So to end my intervention, virtual reality is a technology helping us to approach health in a holistic way. As the World Health Organization said, health is not only a physical well-being condition, but it is a mental and social well-being condition. And virtual reality helps us and helps patients to support the most human aspects of patients' experience, and to promote social relationships. As I said before, virtual reality is not a digital pill. So this is not something that is provided to patients and patients use it passively. It is a process that is promoted and made more efficient thanks to some features of virtual reality. But virtual reality is definitely a portable solution. So you can take a virtual reality headset and you can use it in different hospital departments, and different kind of target patients can access the specific and more efficient content for them just through the same headset, obviously using also specific safety and hygienic routines. It is a flexible solution because you can design a software solution and you can iterate that solution for different kind of patients in order to personalize the content to the real world of any patient. There are no standards of experience. That there is no one solution that fits all, especially in patients' experience. So you really can take advantage of the great flexibility of virtual reality and provide solutions that perfectly fit for every kind of target patients. But virtual reality also allows for data collection. And this is important because patients experience anxiety, pain, social isolation are something that are not seen as a priority in the current care processes, because they fall unseen, they're invisible. We're still not able to measure all these aspects, so we cannot improve them. But with virtual reality, we have a new tool to support patients and to quantify their experience in order to improve, but also to connect that experience to the entire hospital operation. It also promotes multi-stakeholder collaboration, but it requires multi-stakeholder collaboration. And as I said before, with the healing spaces, it promotes continuity and accessibility to the care process. So we can end saying that virtual reality teaches us that space is not something that we should passively suffer. But today we have technologies that helps us to reshape, to rearrange the space in order to promote the healing process of patients. So these are my contacts. We are Softcare Studios. Obviously, you can find me on LinkedIn if you want to go deeper. And I'm super open now to discuss with you, Denise and Jerry. Okay, here it is. Do you still see my presentation?
Yeah, you have to stop sharing.
Okay.
It's at the top.
Yes, but why?
There you go.
Valentino, thank you so
Yes.
much for that presentation. That was brilliant. That was absolutely brilliant. I think one point that I really do want to stress to the audience is how inclusive VR is in terms of age. We have children, we have elderly, we have the whole age span who can really use VR to help in the healthcare system. I really wanted to stress that. And children, they're a very difficult target group to treat as well. So in terms of that, VR is a really good alternative to convince and perhaps persuade children to take on these, let's say, operations and all of these healthcare processes.
Yes, absolutely. I think that when we use virtual reality, we are all children with different ways of playing. So children, they obviously need fantasy, they need distraction, they need specific colors, assets that are able to engage them. When we work with adults and elders, we just need to get in contact with their different ambitions in adult patients. But they also like to play. Even elders like to play, but they just like to play and distract with other things. What we saw even during the pilots involving patients undergoing the blood test, is that on the population level, there are two kinds of patients, the monitors and the blanters. So the monitors are patients who naturally cope with pain, uh, checking that pain. They need to control that pain. So with them, they are less receptive to virtual reality because they don't want to be distracted. And this is very important. On the other side, the blanters are patients who want to distract because they want to look away from the blood test, from everything is painful. So when we use virtual reality, we should take into consideration this difference. With some people, virtual reality is perfect. With other people, is not the perfect solution. So there is no one standard for all. We just need to know patient population and use the solutions that are better for them.
Now, I happen to think that we will go much further in personalization in the next few years as we develop more and more ability to produce instantaneous images. I imagine that by combining artificial intelligence and voice activated apps, you can just say something like, Alexa, I want to see, and it can create something that's slightly different from what already exists. And this will work much better.
Yes.
I think that in the future, we'll look back and laugh at how we tried the same games on so many different people.
Yes, personalization in future is not on the content development, but on the content as experience. Because
Right.
thanks to the artificial intelligence, as you said, I will be able to measure my biometrics with the virtual reality headset, and the system will adapt the scenario to my biometrics, to my stress conditions, to my personality, starting from one basic content, just like we do with dreams. Everyone dreams specific content for the people, for the person. So virtual reality, thanks to 5G, thanks to cloud computing, will be able to provide a very different kind of scenarios that fit everyone needs.
A very recent article on the blog is an interview with Dr. Raphael Grossman, where he summarizes a tour of all of the equipment and the latest. He speaks about measuring the anxiety of a surgeon to understand how they're improving when they go to do an operation. He speaks of using smell. There is a company with olfactory, OVR, virtual reality.
Yes, yes.
So there are many things coming up, and that one article, for somebody who doesn't know, gives a good panorama.
Yes, the future is also multimodal stimulation. So as you anticipated, haptics and other senses needs to be engaged to better immerse people.
Right. Yeah, every set of data gloves, you were speaking about collecting data, wearing the gloves that bring the data, but also measure exactly what you're doing.
Yes, absolutely. But the challenge in the clinical settings is to bring as less hardware as possible.
Right.
So that's amazing that the new interfaces are available on an academic level and even on a consumer level. But what matters is to provide as less devices as possible to the patient, because every device in the hospital settings needs for validation and certification. So this would be really challenging for startups, for every company developing such a solution. So the future is probably enriching the headset with new sensors and complete this biometric analysis on a cloud level. Technology should be really smooth, really simple when provided to patients.
Brilliant.
Yeah, we have some questions in here.
Yes.
Somebody asked me for a link, so I'm putting that. And there's a question about whether you, Valentino, have looked into obesity management, breaking habits, improving lifestyle. I think you can't do everything. It's already enough what you're doing.
So thanks for the questions. We are not trialing now in the UK. We are in contact with people working in the UK, but we are not working in the hospitals there. And yes, we are not working with eating disorders or obesity. This is definitely a very interesting field to work with virtual reality, but it's not focus. It's not our focus at the moment.
Okay, brilliant. Thank you very much. We're going to have to wrap up this live. Valentino, Denise, you have been incredible. This was so interesting. And thank you so much for joining us today.
Well, thank you. It was great to have this opportunity to really discuss, and I look forward to being able to spread around the replay. Yes,
thank you very much, everyone.
Absolutely. Thank you, Denise, for sharing the stage. Thank you, Jerry, and thanks, everyone.
Thank you.
Bye-bye.
Bye-bye.
Welcome back, everyone. We are here with a new set of speakers for the VR and immersive technology open conversation discussion. We have Lucia, David, and Mohammed. If you could all just quickly introduce yourselves and give us a little bit of your background in terms of your VR role. So Mohammed, if you would like to start, please.
Absolutely. Thank you very much for that. So my name is Mohammed. I'm a fifth-year medical student at the University of Leeds. I'm also the founder of Leeds Extended Reality Society. And hopefully today I'll be able to shed some light on some of the challenges that we faced recently and how we overcame them.
Amazing. Thank you. David, if you'd like to go next.
Yeah, David Burden. So I'm Managing Director at Data Limited. We've been working in immersive 3D environments since 2004. My own heritage with it goes back to about 1996. And working in a variety of projects within the health and care space.
Amazing, thank you. Lucia?
So hello, thank you, Jerry. My name is Lucia Pannese. I'm the CEO and founder of a company in Milano called Imaginary. We're a serious game specialist and working mainly in the healthcare area. And lately we've been developing our core product, which is a telerehabilitation system based on games. So in case I would like to discuss a little bit digital therapeutics and the journey that society is doing in this direction.
Amazing, thank you. So Mohammed, if you would like to start giving us an overview.
Yeah, sure. I'll see about sharing the slides. Can you see that?
Yes, we can.
Right, okay, so hey guys, as I said, my name is Mohammed. I'm finally a medical student at the University of Leeds. This presentation was supposed to be with my project partner, Eknath, but he's on placement at the moment and wasn't able to find some sort of suitable time to present. He will be presenting later on, however, the Zoom call, if any of you guys are involved. We just wanted to have a really quick intro to who we are. So this is who I am, that's my name, and I'm the founder of Leeds Extended Reality Society. And in August, we were very privileged to run the first student-led XR conference, and that was in sort of the 1st of August. We managed to get a bunch of speakers from different disciplines from around the world. Some of them are actually presenting today at the Giant event and yesterday. We were very fortunate to have such a good turnout, and it was really quite educational and very thoroughly beneficial. My interests are in medtech, XR, and AI, and I'm an aspiring radiologist. I'll cover a little bit about Eknath, AJ, my project partner. He's also a 5th-year medical student. He completed his dissertation on the use of 360 videos in medical education. He delivered workshops on virtual reality and presented his work to multiple conferences, and he's an aspiring neurosurgeon. So as part of 4th year and 5th year, we have a project called the ESREP, and essentially it's a 2-year project where some students decide what they want to do, and some students go for an audit or something quite boring, in my opinion. So we thought, we'll challenge the status quo and we'll do something a bit more exciting. So the both of us had quite an interest in neurology and the belief that immersive technologies could really benefit patients who suffered from a stroke. Obviously, this is an area that's quite novel, and we wanted to see what kind of things we could do in order to sort of revolutionize this particular technology and bring the technical side and the medical clinical side sort of together. We'd both had previous experience with immersive technologies and wanted to see what we could do. So I've broken down the challenges or the phases into 2 main ones. The first was developing a plan. So we conceptualized a project alongside our supervisors. We conducted an initial literature search, the standard stuff. And we found that there's a paucity of information regarding the use of mixed reality headsets for stroke rehabilitation. And then we formulated our initial aim, which was to understand the views and applicability of Microsoft HoloLens for stroke rehab in the clinical setting. So just so that we're all on the same page, essentially looking at how these headsets can help patients who've lost their motor function, their movement and the power in their upper limbs predominantly. Phase 2 was what we call the untrodden path. Seldom do you find medical students, unfortunately, getting involved in the technical realm. And as a result, it's something that even our supervisors and our medical school wasn't able to help us much on, which is a shame, really, but hopefully we're starting to change that slowly but surely. So the first thing that we did is we shadowed and spoke to multiple neurophysiotherapists, stroke physicians, and patients who'd suffered from a stroke in order to identify the issues within clinical practice that immersive technologies could benefit. We wanted to be that bridge between the two, the technical and the clinical. So we had to do that in order to get full clinical understanding. And then the second thing, in order to get that technical appreciation, was to present our findings and our work in a pitch sort of style to the engineering department, the Center for Immersive Technologies here at the University of Leeds. And we got a lot of really high quality feedback, and we made sure that we utilized any contacts that they had suggested to us as well. Then we formulated a formal literature review on this particular topic, given all of our feedback and understanding of information now. And we began data collection in March of April this year. And we all know what happened around about March and April. We had a lot of hiccups. So we didn't realize how difficult medical ethics was, especially for novel technologies. They really were a pain in the ass at times. Licensing became a bit of an issue as well. Microsoft HoloLens had very specific sort of guidelines in terms of what could be done, how and where, and so on and so forth. And this did cause some substantial delays. We did feel this was very much an untrodden path. We had to create the path ourselves, and then we had to walk that path. So it was difficult. We didn't have any map, we didn't have any guidance, nothing like that. Our tutors' experience did actually become a hindrance at one point because they're used to standard technologies and so on. So they can only give us advice on what they know. And as such, we have to sometimes freestyle ourselves and do what we can in order to sort of help progress this project. And then, of course, COVID affected us all. We weren't able to sort of deal with patients when the staff in the NHS, understandably, were under a lot of pressure. We were drafted in to do certain other jobs to help the situation. So it was difficult for us to continue with this project. However, there are a few interesting things that we actually benefited from through speaking to patients, speaking to staff, and speaking to the engineering departments. The first thing is that the involvement of stakeholders is extremely important. Individuals felt that there was a dissociation between the technology and the innovators and then the day-to-day clinical practice, which is something that we actually want to address moving forwards with the medical schools across the country. They also felt that, in order to make sure that they're involved in every step of the process, there needs to be a continuous review process. And then we felt that the literacy of some of these technologies is not particularly good. A lot of people are technologically illiterate, unfortunately, and this becomes a bit of a hindrance to progress. There's a lot of misconceptions out there about XR, for example, in our particular case, being something, too futuristic or sort of unreal, which is something that we definitely are trying to work on. And we feel that more research on these preconceptions of these technologies is important because, unfortunately, these misconceptions then become a barrier to entry of this particular technology because people are less willing to take on the technology, they're less willing to engage with it, and so on and so forth. So we need to study the preconceptions more within the healthcare sector, obviously, in my particular case. In terms of usability, we had some concerns over people being able to use it autonomously. And what happens if it breaks, for example, or if a patient has a stroke, they may be cognitively declined, and the family members would need to use it. We feel that gamification, as a lot of the other sort of pillars of XR, is quite important, and progress reporting is something that would help us tremendously. There needs to be clear need for tools to give feedback both to the patient and to the clinician. So how is the stroke patient sort of improving from a motor point of view? Are they getting feedback about their own progress? Is their clinician getting feedback about their progress, and so on? We feel that the technology needs to have a really, really clear purpose and a defined effectiveness. And this is perhaps something that needs to be worked on within the XR medical sort of realm. There's a lot of tools that are being developed, but not necessarily to solve a clinical problem. They're just being developed for the sake of being a tool. And hopefully using something like XR, we can move away from clinical practice, especially with COVID. There's a lot of stuff that's being done remotely at home and so on and so forth, as there is more demand on the NHS. And there's a greater sort of caseload. So if it's something like XR would be of great benefit. Now, one thing I really, that does really sort of resonate with me is when Steve Jobs said, you can't connect the dots looking forward, you can only connect them looking backwards. And this is, I think, looking back now is really what had happened. What we were really keen about is to be sort of optimistic, utilize opportunities as much as possible, and do what we can to sort of remain enthusiastic and willing to improve. So very thankfully, I managed to set up this Leeds Extended Reality Society, and this is our committee at the moment, a fully functional committee. We've had lots and lots of events that I'm going to shed some light on in the future, and really we utilized or sort of, we bounced back from something that was, quite devastating, weren't able to do our projects and so on and so forth, to actually setting up something that can hopefully help students in the future. Now, our mission statement is to be like that connection in the middle of those ropes. It's to build a university-wide platform, so that's for all students, and then that involves students, academics, and external organizations to collaborate, innovate, and shape the future of extended reality. So really, it's all about that trio of students, academics, and the external organizations, so that we can help students move into the XR realm and really help develop the XR realm. Now, when we started off, we had a few points in our plan, all right? We wanted to have a range of events from XR lecture series, where we have at least 3 speakers, one sort of covering each of our triad, if you like, one covering the student perspective, one covering the academic perspective, and one covering the end user / the industry perspective. I've already had 3 of those. We've had XR in medicine, which was fantastic. XR in engineering is coming up. XR in radiology, XR in business and enterprise, and really, really good turnout for each of those. We want to have skill workshops for students to learn about Unity, for example, and coding, and the things that would help them develop into the XR world. We're going to be getting in touch with games and software companies in order for them to use our platform as a bed for testing. We want to have careers events in order to propel these students into the XR realm. We want to hold conferences and industry exhibitions, hackathons, and collaborations with other technologically minded societies. One of the great things as well, actually, that we wanted to have, and one of my personal dreams, is to have lots and lots of student-based extended reality hubs across the world, where hopefully within the next 2 or 3 years, we can have a really huge conference where we can discuss some of the problems that we face within the XR sort of universe, if you like, and how we as students can work together on projects and so on and so forth. And luckily, we have been working on this blueprint, and we've been able to help the University of Southeast Norway to set up this XR Society, and we've also helped the University of Birmingham VR Society to set up and sort of take some solid steps. So in terms of what we've done so far, I've highlighted in green what we've done. We've had a number of successful XR lecture series. We've had our conference at the beginning of August. We've collaborated with other societies, and we've helped set up a couple of other societies, even during the COVID sort of pandemic and lockdown and difficulties and everything being virtual and so on. So to conclude and bring everything together in terms of our Ezra project, our medical project, and then the setting up of the society, we feel that a lot of these technologies, especially within the medical realm, are an untrodden path, unfortunately, especially for medical undergraduates. We feel that in order to improve things, we need to embed it within our undergraduate curriculum in order to sort of plant the seed earlier on and get students thinking about how such technology could be used within clinical practice. We feel that more research into the hindrances of uptake is necessary so that we know that why staff feel the way that they do about AI, for example, about automation, about extended reality. One of our questions is the NHS really ready for technological innovations, or is it unfortunately led by people who don't quite understand what technology is or even means? We want to connect with clinicians and innovators, and we want to make sure that they speak to each other so that one isn't sort of going in a certain direction and the other is going in a certain direction. And there's a mismatch between what the aims and objectives are from each side. We feel that tech literacy is quite an important thing, and we need to make sure that more and more people are able to use this technology and understand the abilities of these technologies. And we do go by the saying, and I think a wise man once said that those who live in the future shape the present. And hopefully we can be amongst those who are so sort of innovative and futuristic in our thinking that we shape the present. Just a special thanks to those who helped us, our two project leads, Mr. Gareth Frith from the Leeds Institute for Medical Education. I understand that he presented yesterday. Dr. John Cooper, who is a consultant neurologist. Mr. Chris Brown, the head of Centre for Immersive Technologies at the University of Leeds. Mrs. Maddie Kenny, who's a neurophysiotherapist, helped us a lot during the inception of our project in terms of guiding us the right direction. And Dr. William Bolton from the ACIT, he's the innovation lead over there, and my sort of Leeds Extended Reality team for being so fantastic. Here are the QR codes for our social media pages. Feel free to, just use your phone, take a photo, or go to the pages. We're most active on Facebook, although we do use the other platforms quite a lot. So, feel free to check us out, get in touch. If you have any queries, any collaborations, any support that you can provide us. One thing we are working on is funding. We don't have any funding from anybody whatsoever. Everything that we've done has been either out of pocket completely or through the goodwill of presenters. So if you'd like to work with us, maybe we can help you somehow, and you can help us from the financial point of view or speakers or something like that, then please do get in touch. So yeah, my name is Mohammed. I'm the founder of Leeds Extended Reality Society. Thank you ever so much for listening. And do you have any questions?
Mohammed, thank you so much for that presentation. It was so engaging. Let's just start off by saying, you mentioned about misconceptions and overcoming misconceptions when it comes to immersive technology. Yeah. How do you think, in terms of healthcare, let's say the NHS, and implementing these virtual technologies, how do you think we can overcome this issue and misunderstandings when it comes to the technology?
So I think that's a very good question, and I think that's definitely part of the solution to be asking these very tough questions. The first thing is hopefully something that we'll be working on, which is actually having quite a big audit/survey looking at the staff beliefs about this technology and how they feel it could be used in the future. We feel that in order to get someone to use something, you have to get them to sort of understand what it is. Maybe try it out, almost like a new toy. Maybe use it with some pre-existing platform, like they could play a game on it or something like that. Once they get a feel for it, they can then give you an idea of what they think it could be used for in the future. And that's exactly what we started doing with our clinicians and our patients. So hopefully, beginning of 2021, after my finals exams, we plan to have quite a big project that will start in Leeds, but probably will span out elsewhere, where we look at the opinions of staff about this technology, just to see what they're saying in general, what their beliefs are, and then what they think moving forwards this technology could be used for. Given that information, we can then, run pilots, we can do testing and so on and so forth. We can have specific sort of clubs for people who are interested in this kind of technology. They can then become our spokespeople and get the message out there, hopefully can trigger further research and so on and so forth. But without that initial information about what's already out there, what the opinions are that staff have already, it'll be difficult really to navigate through this situation that we're in.
Yes, of course. Thank you. So in terms of the future of immersive technology, with regards to, as you said earlier, stroke patients, where do you believe this will take us?
So I think the future is very bright with immersive technologies for stroke patients, to be honest. From the work that we did and the research that we did, we can definitely tell that it's one of the biggest solutions and the best solutions actually to the situation that physiotherapists are finding themselves in at the moment. There is an increasing demand for physiotherapists in general, not just for stroke patients, but for other patients as well. And as a result, you need to find other tools to almost free up the physiotherapists from the stroke patients or specific category of stroke patients. Then they can, put their attention to other things. In the same time, we want to give patients the autonomy and the ability to do things freely. Like, for example, stroke patients, for example, are supposed to have at least one 40 to 45-minute session of rehabilitation per day following a specific subcategories of strokes. All right. This is virtually impossible within the NHS. All right. I have to say that sort of clearly, because of the demands, unfortunately, that staff find themselves in. Something like a headset where you've trained the physiotherapist to use it, you've trained the patient and you've watched them use it a couple of times, and they now feel confident in using it correctly. That would be fantastic. One, it gives the patient feedback on their own progress, okay, in a numerical sort of quantifiable manner. And at the same time, it gives the physiotherapist or the clinician feedback on how they did. And the physiotherapist could get in touch with the patient. So something like that could be used in the hospital, i.e. the patient puts it on after they've tried it a few times. They've now gotten used to the technology. The physiotherapist has vetted that, okay, this patient can use it now. Okay, they have a session per day where they use this headset. All right. And if they go home, then this is something that we may be in the future be able to send patients home with. All right. So they take the headset, they're borrowing it for a specific amount of time. And this is definitely the direction that we see medicine moving in, sort of the telemedicine and the remote sort of monitoring of patients, or the remote care where patients are at home in their own sort of natural surroundings, but they use some of the things that we would use in hospital. Headset, obviously, in this particular case. Hopefully that's part of the future. I think it would be quite a big move, I think, within healthcare.
And of course, time is money, especially, let's say, in regards to the NHS. We need to have all of the people working in the NHS in as many sectors as we can. So in terms of you saying it will save time, it will actually save the NHS money, is what you're saying.
So the concept of time is money is definitely an interesting one. I think money is a variable currency, and I think time is priceless. So in terms of sort of hard facts, we know that, for example, a standard patient bed costs the NHS £500 a day. All right, from the medical staff to the average sort of medications and care and so on and so forth. So being able to send the patient home, where they're in their natural surrounding, using the technology in their natural surrounding, making recovery, where other patients are seen in the hospital who may be more unwell or more sort of acute in their presentation and they require more attention. That to me is something that is worth a lot more than money, personally, because it not only does it speed up the progression, because the patient is at home in their natural, comfortable environment, so we get more accurate, representable readings, but in the same time, those who actually do need the care are in a sort of a very space and resource limited hospital, they are getting the care that they need. And then the physician or the physiotherapist is getting feedback from the patient who's at home, just keeping a tab on them. How are they doing? How are they progressing? And so on and so forth. So yeah, in essence, it does save us a lot of money, but it also helps with the progression of care, with the quality of care, and how fast the patient can bounce back because they're in their sort of natural surrounding, i.e. at home.
Yes, brilliant. Thank you for that. So if anyone has any questions, please do put them on the chat, and Mohammed will be able to come back to you. David, let's continue with you with this discussion. Hello, David.
Yeah, that's all right. Just switching camera back on. Right, okay, I'll just fire up the screens. Right, can you see my screen okay?
Yes, we can.
That's great. Okay, so just give you a bit of background to some of the things that we've been doing within this space over the last decade and a bit, actually. We're a small company, we're based in Birmingham, but I've been personally involved in virtual environments since about 1996. And as a company, it's pretty much all we've been doing since around about 2004. And what I would do is give you a quick run through some of the projects we've been involved with, and then draw out some of the sort of the more general issues, and some of which touched on some of the things that Mohammed was speaking about just then. In fact, actually, my first project is actually quite closely aligned with some of the things that Mohammed was talking about. So one of the projects we did was with Birmingham Community Healthcare Trust, and that was working with patients with acquired brain injury. And apparently one of the things that's quite common is that they lose the ability to actually be able to navigate. And so what we did is we built an immersive environment, which was very bland. It was just the same house basically repeated over and over again in a grid type layout. But then the researchers could then introduce into that environment what they call proximal and distal landmarks. So proximal landmarks are like a telephone box. Distal landmark is something like a church tower. And then by using different combinations of those, they could both look at what the effect of the damage to their navigation skills were, and then look at also how you rehabilitate those. So they could actually lay out a route using some arrows, get the patient to navigate that route using the combination of the arrows and the landmarks, and then gradually remove the arrows and then see if they could still navigate the route. And that's been used on a number of research projects. They did some actually inside an fMRI scanner, so looking at what was happening in the brain as people were going through the route learning side. More of our sort of bread and butter type work. We've been doing some work with the university on diabetes and training nurses to identify problems, diabetic problems in patients, and then how to deal with those. And you get some idea there of some of the feedback we were getting from the students, nurses who are using that system. We've also done work around urinalysis. We get involved in all the really exciting things. Urinalysis procedures, so again within a clinic setting, so dealing with an expectant mother going through the urinalysis procedure, and then doing things like making sure you get informed consent, making sure you're checking dates on bottles, making sure you do the procedure correctly, deciding how you feed back to the patient. And so this is the sort of thing you might do within a classroom type environment with an OSCE, with some sort of an actor. But obviously that can only be done when that's arranged, whereas here it's something that students could get access to 24/7. And one key thing to note, I'll move on to in a bit in a moment, is that almost everything we do is designed to be used both with a VR headset, but also with an ordinary smartphone or a tablet or a PC, because we recognise at the moment, and probably for always, people will not always have access to VR headsets. VR headsets have got good points and bad points, which I'll go on to. So it's quite important for us that the students have the ability to access this sort of learning in any situation. A little bit older, but still valid. One of the things we found these environments are very useful for is doing virtual lab skills. So time in a physical lab is often very limited, and obviously at the moment very problematic. Whereas actually if the student can go into a virtual lab at the beginning, rehearse what the task is going to be, it means they're actually far more prepared when they go into the physical labs. They're not wasting time just trying to work out how you connect this to this and things like that. But the other big advantage we found was that when they're actually inside the lab, we can combine the theoretical training with the practical training. Because apparently it was reported by the lecturers, a lot of students had issues linking the theoretical lecture they might have had a fortnight ago with actually what happens when they turn a knob on a device within the lab. And so what we're able to do, and it's shown in the picture bottom left here, is actually as they were interacting with the equipment, we could actually show what was happening at a molecular level, so as to help embed that sort of learning. More recently, we found ourselves actually moving sort of out of the hospital, out of the clinic, and looking at things like social work training, home visits for nurses and midwives. Again, it's a situation that's very hard to train for and very hard to actually practice within a school environment or within a college environment. So here we're able to reproduce somebody's house, and they actually go in there, they need to talk to the mum, they need to talk to the dad, They might want to inspect the baby. They might want to talk to the kids if it's a social care type situation. And again, they can sort of navigate their way through that, picking up on cues within the environment, trying to choose how they approach the mum and dad in conversation. And it's a chance to practice that within a safe failure type environment. And one of the other things that we do quite a bit of within 3D is actually looking at data visualization. And so this thing here is a protein, it's the P53 protein or something, visualized in one of our platforms. We're looking here at adenocarcinoma tests. So that ability to take data into a virtual environment and into a 3D environment can give you a very different perspective on the data. And it's to do with this thing's called egocentric and allocentric. Which I won't bore you with now, but within the virtual environment, you're in an egocentric environment, and that's how the world works. The world is egocentric; it all revolves around us. So actually being in that sort of environment with the data lets you see patterns that you may not otherwise see when you're just looking at it in a more conventional way. So that gives you an idea of some of the sorts of projects that we've been involved with. I just want to sort of draw up a few more sort of generalities now. You know, when you're thinking about what you're going to do in this space, we found Bob Stone, who's a professor at the University of Birmingham. He's got a very good model called the 3 fidelities model. And that says what you should be thinking about is what's the fidelity you need for the environment. So for the ward, the clinic, the operating theatre, you know, basically how many pixels do you want to spend creating that environment? And it's definitely a law of diminishing returns. But it needs to be good enough that people feel happy with it and they recognise it, because that actually helps with recall cues later on. But you don't want to be spending probably 6-figure sums creating it, you know, leave that for the movies. What's most important for most of what we do is about the task. It's the fidelity of the task. So what are the sequence of actions that you need to go through in order to achieve this task? And what are the implications of doing those actions or not doing those actions? And so that's very much what a lot of the training work within this space is around, is around the task type training. The thing that certainly the VR immersive 3D has been less good at in the past has been interaction training. So thinking about the haptic piece of actually how do you say put a needle into somebody's skin. And what I was always told by medics is the best way of doing that is to practice on a banana, because a banana bruises so easily. Whereas, you know, trying to do it in VR, you can do it, but it's not particularly rewarding. But obviously we are seeing improvements in haptics at the moment. So, you know, over the next few years, we'll probably see more and more of those sorts of things that previously we would say you couldn't do within a virtual environment, becoming more feasible to do within some sort of VR space. And one of the things we've actually just blogged about it this week is we've taken those 3 fidelities and we've mapped them against some of the conventional learning tools. So watching a video, being involved in some sort of video conference like this, taking part in some of the sort of traditional e-learning or virtual patient type exercise, or the immersive 3D and VR environment, and looking at how each of those plays into these 3 fidelities. Let's say you can find that on our blog. And as I mentioned earlier, one of the key things for us is this sort of choice of 2D, 3D, or whatever you want to call it, the first-person shooter Sims type environment, or Minecraft, you know, where you are looking at a 3D world, but you're looking at it through just using a handheld or a tablet or a computer, and contrasting that to headset-based VR. And obviously, all the fuss over the last few years has been around headset-based VR. And whilst it is brilliant for some things, it is not a lot of good for some other things. You know, for instance, you know, text input and output is absolutely next to impossible. Something like 10 to 20% of people, the minute they put on a VR headset, want to take it off again. So you're immediately disenfranchising a bunch of the audience if you start to do that. You've got to have health and safety issues. You're totally isolated. And obviously, in the time of COVID, then not everybody's got a VR headset at home. With a 2D, 3D type platform, you might not get that complete sort of last 5% of immersion, but it's available to absolutely everybody. And certainly you can do very long, you know, we've done 5-hour simulations for City of New York in a 2D, 3D. You wouldn't do that in VR, in headset-based VR. So for us, you've always got to be quite sort of agnostic when you're developing stuff, and make sure you've got that option really to experience the training in both modes, accepting that headset-based VR is not always going to be available, and even if it was, it's not necessarily the best way of doing things. And so the way we achieve that is we have our own authoring system called Trainingscapes, which lets us actually build these exercises and actually publish them to both VR and non-VR type users. I'm not going to delve into any detail on that at the moment, but the key thing for us is it has its own authoring environment, authoring tool built into it. So what you see is what you get, code-free environment. And so potentially it means we can actually work with e-learning teams, potentially even practitioners and SME subject matter experts and even students, and actually get them to create the simulations themselves. They don't need to come to us to actually get those created or changed. And you know, our focus is based on providing the technical platform. Realistically, we normally help projects get started, but then we're quite happy to take a step back and let everybody else take over. And just to finish off, I mean, this is an interesting chart. This is looking at, this is something called Relive, and it's looking at sort of what the short, medium, and long-term challenges might be within this space. So the short term is all about, you know, making this nice and seamless, making it nice and easy, and also, as Mohammed was talking about, it's about making it desirable. How do we get people to really see the benefits? The medium term is about, as I say, things like being able to get this onto mobiles, which obviously offers processing challenges. But also being able to make it unified, so we're all on different platforms, so we don't have to dive in and out of different platforms to get access to different lessons. And the long term is the more radical interfaces, so you know, shrinking the size of that VR headset, and also the implications of societal change that might have, and COVID obviously is driving some of this. To me, the most interesting thing about this chart is it's 9 years old. This was from a VR conference at the Open University in 2011. And the sad thing is we haven't actually progressed that far on it. And ironically, the thing that we've progressed most on is actually the radical interfaces and getting VR headsets, which we expected to be happening about 2025 or 2020. We had a lot earlier, but where we have not made as much progress is in this area about making things desirable. And on that note, I'll end.
David, thank you so much for that overview. That was amazing. You're doing really great things in the VR world. So let's just talk a little bit about ease of usability and practicalities of VR. If you could just explain in terms of practicality, say in terms of a patient, how that would work for them.
I mean, it's the practicality of VR is, there are a number of different dimensions to it. What we are seeing with Oculus Quest, I think, is probably the most usable instance we've seen of VR so far, because certainly you need what's called 6 degrees of freedom. So you need that ability to move laterally as well as turn the head. To do that, you've got to have reference points. Up until the Quest realistically came out, that meant you had to put sensors in the room and things like that, which is extra baggage, which a patient is never going to do. Whereas with the Quest scans the room, it builds its 3D model, and it's got that there. And so the fact that you can just put, and we're seeing that on other headsets now, but that fact that you can just put the headset on instantly sort of lets you draw in a safe space, and increasingly it's now looking at detecting intrusion into that safe space. The mechanics of actually putting the headset on and getting to the point where you're safe and it's working are suddenly a lot easier than they were, you know, 2 years ago. Once you've got to that point, though, you've then got to get access to the exercise. And this is where, certainly with Oculus Quest, you've increasingly got the issue of a walled garden and sort of Facebook control coming into it. So for a lot of the applications that people are doing and developing as research projects, they have to be side-loaded onto the headset. Quite honestly, no patient is probably going to do that. So you've got to give them a headset with the application already on, which is obviously problematic. That's one of the reasons why what we've been doing is looking increasingly at what's called WebXR. With WebXR, basically, once you've got the headset on, you give them a URL, and they use the browser inside the headset to get to that URL. Once they reach that URL, that little button pops up that says, do you want to see this in VR? You click on it and say yes, and suddenly the browser disappears, and you are stood in that 3D room. And you can interact with that 3D room as with any other VR. And so instantly you're able to deliver a changing VR experience to a patient without having to constantly upload software to their headsets. And that to us is, again, a big game changer in terms of making this stuff accessible. And then once you're in that environment, then obviously you want to make it as intuitive as possible. You're beginning to see sort of design patterns emerge about how to do things. You want to be following those design patterns in terms of things like how the joysticks work, how the buttons work, so that people have got some sort of familiarity really before they get into the environment about how it's going to work.
Yeah, brilliant. So let's speak a bit more about long-term goals. You mentioned earlier a few long-term issues. If you could further explain these, please.
Yeah, I think probably the one that we originally had down as medium term, but is probably now long term, is the issue of how you connect all these different environments together. Because what you don't really want to do is if I'm doing something for one subject, I go into one platform. If I'm doing something for another subject, I go to a different platform. We don't do that on the web. That's how we started before the web, because we all had all the different AOL type environments, Microsoft environments, but all of those eventually became the web. So what we need to do is get to that version of the web that's in 3D, and sometimes people refer to it as the multiverse or the metaverse. And WebXR is a good route forward to that, because it means that I can host stuff on a web server, I can create the environment. What we want to be able to do, though, is basically if I'm in one WebXR environment, I want to be able to click on something that takes me out of that WebXR environment and drops me into a totally different one, but takes with it my personal identity, if you like, so the equivalent of the information that's stored on your cookies. Of course, the ironic thing is we haven't even got that on the 2D web yet. Every time I go to a conference, I've got to fill out yet another different set of data. So it's a challenge to the 2D web, let alone the 3D. But just that ability to be able to drop in, go to a conference, go to a seminar, go to work, go to a bit of training. It's all being delivered through some sort of common standard that one piece can interconnect to another. To me, would really help sort of drive this forward, rather than having a large number of walled gardens.
Yeah, brilliant. David, do you have anything that you would like the audience to know? Any comments, or would you like to explain anything?
No, I think probably to cover most things in the presentation. But I say for us, I think the key message for us is about how do we democratize this? Because where we are with VR is realistically where we were with, I know we call them digital slideshows before PowerPoint, for want of a better word. And, in the old days, whenever a big corporate was getting a presentation ready, it would usually go out to a design agency. And that design agency would create the slideshow for them, maybe with a bit of fancy video and lots of fancy fonts and pictures. But of course, in time, everybody just started using PowerPoint themselves, and they created their own content. And we need to get to that point with VR, basically, in immersive 3D. We need to give the tools to the subject matter experts, to the e-learning people, so that they can create the content rather than having to come to specialist agencies every time they want to create a new piece of learning.
Yes, brilliant. That's a brilliant point. David, thank you so much for that. Lucia, if we could have an overview from you, please.
Okay, yes. Let me try and see if I can also share my screen, which would be great. Do you see my screen?
No, we do not at the moment.
Fantastic.
There is a button on the left.
Now?
Yes.
Okay.
Yeah.
Brilliant. Okay, here we go. So thank you, Jerry. I would like to tell you a little bit about the roadmap to digital therapeutics, what is going on in this area, and how serious games fit in this picture. So just very, very briefly about our company, we're a multidisciplinary team, which means that psychologists work together with engineers, with game designers, and with graphical artists, maybe. So since 16 years, we work in serious gaming, and particularly what we do is combining game psychology and game mechanics into technologies. And what we aim at is, in the end, targeting some behavioral change. We do that mainly in e-health, and we always start from big research projects. We have been awarded over 30 EU funded projects in the meantime, and we have picked some years ago as one of the best practices in silver economy by the European Commission. So with this background, what is going on in digital therapeutics? Well, actually, we know what that is a subset of digital health. And actually, we think that serious games have several characteristics that support digital therapeutics quite in a natural way. When we talk about serious games, we want to keep a patient very active. Actually, we put the patient at the center of an experience. We pay very much attention at motivating a patient. We target some behavioral change to improve patients' health and, in the end, patients' quality of life. And we target adherence. So we want to improve adherence to therapies, which we know is a topic which is always quite critical. So if I may use terms coming from pharma, then I could say that serious games are a perfect excipient. So serious games are a very natural means to delivering some digital therapeutics. Let's have a look at the challenge. We've been mentioning that in some talks before. We know that in general, NHS systems are under an enormous stress. Actually, there was a policy by the EU, one of the grand challenges about this topic. We know we have several areas of chronic diseases, and we know that the ratio between the number of specialists and the number of patients is getting worse and worse every year. So there's not enough specialists to deliver the needed therapies for and the needed length of therapies for all the patients that we have there. I have here on the chart only the numbers, the figures about neurology. So this is already amazing, the number of people involved there and the costs involved for only European NHS systems, but it is a global problem, which is made worse now during the pandemic. So we know that chronic patients have been left behind. For example, oncology patients or cardiac patients have not received the therapies they needed, which is again making the problem worse. And we know that starting from a situation which is critical already, medical staff is even at risk if they are treating patients. So we're in a really urgent need of getting digital scalable solutions to solve this issue. Actually, Eurostat shows us that there is an increasing tendency of having home caring professionals, but this is clearly not a scalable solution. So what we need is something that solves the issue in a scalable way. And actually, we saw already that during the COVID pandemic this year, there was a rising interest, and COVID accelerated uptake of digital health solutions. So now I'm looking through the lens of telerehabilitation a bit more in detail on what is going on. Let's have a look at the stakeholders that we have. Clearly, patients are at the center of the whole story here, but we don't only have clinics, hospitals, and the NHS systems. We have many more stakeholders involved in the process. We have policymakers that have to look together with the NHS systems at legal issues, ethics, reimbursement policies, and so on. We have quite a big amount of medical producers who have things like home monitoring or televisit solutions, wearable systems, and so on, but these are all scattered. We have pharma industries, which are extremely interested in facilitating the uptake of digital therapeutics. And of course, we have the training area, which is taking care of medical education in terms of education at university, but also credits and ongoing education. The connection should not be only among technologies, not only among people, it's also among different places, so clinics, homes, among different areas. So the social aspect should also be taken into account. But in this whole picture, while we have to engage patients and while we have to collect more and more data and put them together to get a homogeneous picture, we still need to deliver a very personalized therapy. So let me briefly show you with a little piece of a video how we solve this issue with our main solution. Okay, this is enough to just give you a little bit of flavor of the look and feel of the solution. So what you saw was mainly a neurology patient, unfortunately, using our neurology solution, which is in the meantime a medical device, a very scalable solution. And one of the main issues here is that, of course, the system was designed together with neurology teams, but it was very closely co-designed together with neurology patients, because when you want to serve some patients with such a solution, when you want to boost motivation and make them adhere to a therapy, you have to very much look into what is motivating them. So you really have to co-design games for them. Actually, we've been working with patients between 60 and 95 who are clearly not digital natives, and where very many people say, well, these kind of patients are afraid of technology, they will never use it, and so on. But this is absolutely not true. The point is that technology needs to be designed for them and not in general or for other target groups. So actually, what we've been showing is that we won quite an amount of international awards, which interestingly enough come from almost all the stakeholders that I've been showing before. So the NHS systems, the neurology scientific area, patient associations, and the big players in the healthcare industries abroad. The outcomes show we have 22 scientific papers about these systems out there, that actually motivational indexes are over 85%. So between 60 and 95%, 95 years, sorry, 85% of the patients like this solution. They prefer it to traditional therapy, and they would even suggest it to peers, which is quite amazing. Efficacy is exactly the same as traditional therapy, and of course it's higher than other solutions that come from commercial games, which are not designed for neurology. What we expect is that we get more outcomes, something like that therapists can raise the number of patients they treat by 40%, and that about 80% of the patients actually can be treated remotely. There will always be some 20% of patients who really, really need to be together with therapies. One emotional side that shows you how patients feel is that an association reported that patients who were feeling as losers in their lives reported they were able to win again. So actually this tells you about the emotional involvement of patients with these kind of solutions. Again, more in general terms, where are we going with digital therapeutics and these kind of telemedicine solutions? Well, actually, we expect a very broad adoption of these kind of systems. There's clearly some further need for clinical and longitudinal studies, because in the longer period, we still need to report if motivation is keeping up, because as our colleague reported before, neurology patients very often train something like 45 minutes per day. So actually it's not exactly super easy to keep them motivated in the very long term. We have to clearly see if adherence keeps up in the longer term, and what happens with new occurrences, because what we aim at is reducing new occurrences. Of course, also, we expect a better quality of life, because if people stay at their homes with their beloved family and so on, they will have the feeling of being cared for versus being abandoned, because after a couple of months of therapy, normally they have to stay at home because other patients need treatment. So actually we expect them to feel better. And of course, they will have to go less to hospital, which is of course much easier. There's still some barriers to adoption, to be very honest, but we all know that. And they're mostly coming from organizational issues, because digital solutions cannot just be given to clinics or the NHS. They need to be seamlessly embedded into clinical routine. And this has to go through some innovation of organization, particularly working processes, legal processes, which are not there now. We still have to demonstrate some cost savings in terms of ROI of telerehabilitation. And of course, there will be some needs in terms of training of therapists, clearly, and a little bit of patient training and empowerment. But this is, in my opinion, the least critical issues. The biggest issues are the organizational ones. So this is about what I wanted to tell you. You have my contact details here, and I'm very happy to get people contacting me or taking questions now. Thank you very much.
Lucia, thank you so much for that overview and that presentation. Also, I really enjoyed that video you put up. Brilliant. So let's just start talking about personalization of therapy. You mentioned this briefly in your video. So you mentioned that the age group 60 to 95, actually, these people, perhaps they are not tech savvy, but we need to actually adapt the technology we are using to suit them. If you could talk a little bit more about that, please.
Of course, very good point. Actually, the technology was developed for them and together with them. So actually, in the biggest picture, it doesn't need to be adapted because it was already created in a way that it motivates them. So, for example, several games are what we call ecological games. So they're very closely related to daily life. For example, autonomy at home, because one of the issues that is motivating elderly people clearly is to be autonomous, not to be depending on other people to do, say, very simple things at home. So very many games are related to that. So elderly people see the point, they understand why they're doing the exercises, because if you do an exercise, well, say in a room without anything in front of you, you don't even know sometimes why you're doing that. But if you can relate that to an action like putting away your coffee cup or whatever, then you know why you're doing that. And these games already target this motivation. In terms of very fine-grained personalization of the exercises, actually the system has what we call a doctor station in the background, which is a sort of dashboard for the specialists, and every game is parameter based. So it's not only how long a game lasts or how quick elements move, but it's really portions of the screen, number of elements, number of distractors, very, very fine-grained details, which are more complex to explain than to do for a specialist, that make the exercise exactly personalized for that patient in that moment of the therapy.
Brilliant, thank you. So you also mentioned that already in your statistics that there is a preference towards digital therapies at the moment, digital solutions. Could you explain that a bit further, please?
Yes, very many patients, we are talking about neurology patients. So these patients are very fragile, they have pain, and they suffer from fatigue. So very many of these patients complain a lot. So if you ask, for example, therapists, very often they're stressed because patients complain a lot. They don't want to do exercise because it's hurting, because I don't see the point, I don't see the improvement. But sometimes avoiding a deterioration is already, unfortunately, a very good result in terms of the pathology they have. So they're quite negative very often in their attitude. But if they have a game in front of them, first of all, their concentration is very much on the screen, so on the game, and not on the pain or the movement, which makes the movement smoother and more natural. And they really, from the therapists, we have reports that they forget to complain about fatigue and pain. And instead of just wanted to leave the therapy session, they really want to play the game to the end. So although maybe the 45 minutes are over, they say, well, wait a second, I want to see if I'm scoring better than last time. So this tells you quite a lot about their engagement in the therapy, which is making their lives easier, and actually the life of therapists easy as well.
Yes, yes. So with COVID-19, it's really highlighted the issue and the need for digital therapies at the moment. Could you comment about that, please?
Well, of course. I mean, this system was already designed. We started development and studies 8 years ago. It was designed since the beginning to do telerehabilitation. So, of course, when you finish a therapy with a therapist and you discharge a patient, you can give them a kit to take at home so that they can use our system through their TV screen. So this is keeping patients at home safely, of course, therapists as well, because their safety has to be cared for as well. And what we're doing now is developing the cardiac and the respiratory versions, and other versions are planned as well. So in the longer term, if we really succeed in treating about 80% of patients in this way, imagine if in the hospitals you have about 20% of the patients you have today without leaving anybody behind. So actually, I really think this is a support in the case of a tragic pandemic like what we're living now.
Yes, definitely. So in terms of an organization level, you mentioned there are difficulties transforming therapies into digital therapies. Could you explain that a little further, please?
Well, I'm not sure what you mean, like transferring therapies into digital therapies. First of all, of course, you need studies. If you mean the process of creating such a solution, of course, you need to investigate quite closely what is being done now in traditional therapy, because when you offer a digital solution, you don't want to lose any efficacy, and patients need to be treated at least with the same quality level that they have today. It's perfectly clear. So you need to involve actually different teams in the same pathology area, also because you find out that there are some sort of philosophies, if you allow me the term. So not all, first of all, not all have the same exact picture of patients, even in I'm talking about the same pathology environment, and also not all work in the same way. So you have to have a very flexible system that allows specialist team to keep working in the way they are working already with the patients, offering the flexibility of tuning the therapy for the single patients, offering them scalability to monitor data in the way they wish, or exporting them if they do research, for example. And then you need a lot of tests, piloting, and validation, of course. So it's actually quite a long process. I mean, it took us 8 years with EU-funded research. So we were funded by the European Commission, first of all, through 2 different projects to do this system. And then we went on piloting and validating it also in Asia and so on, with other teams and situations. So it's, if you want to do something which is safe enough and careful and flexible enough, it takes quite a long time.
I see, I understand. Lucia, do you have anything you would like the audience to know? Any further comments?
No, thank you. I mean, I'm happy to get emails or contacts through my social networks if anybody's interested.
Amazing, thank you. So,
thank you.
Mohammed, Lucia, David, thank you so much for taking part today. That was amazing, and I think you've all definitely given us a very good insight into immersive technology. Thank you very much.
Thank you, Jerry.
Thank you.
Yeah, thank you.
Thanks a lot, Jerry.
Thank you
very much for joining us. Armin, if you'd just like to introduce yourself, please, and the company you work for.
Yeah, hello there. My name is Armin Kuhner, and I don't work for a company. I am a consultant surgeon at the Royal Papworth Hospital in Cambridge, UK.
Brilliant. Matt?
Hi, I'm Matt Morgan. I'm the founder of a immersive production company called The Original Content Company.
Brilliant, thank you. So, Armin, if we could start with you, please.
Yeah, are you ready for me to start my presentation now?
Yes, thank you.
Okay, all right. I'm going to, I will, yeah, hi, can I just, sorry to say this, yeah, I'm actually hearing an echo of what I'm saying, which is about 15 seconds behind.
Oh, right, okay. If Matt, and I will mute.
Yeah, okay, I can no longer hear the echo. Okay, it was a little bit confusing. Okay, well, good afternoon, everybody. I'm hearing my echo. Can you stop that echo?
Okay, one moment. Please bear with us.
Then please do. So let me start again. So I will start a screen share and hopefully you can see my presentation. I'm a consultant surgeon at the Royal Papworth Hospital in Cambridge. I'm going to divide my talk into 3 parts. Okay, I'm really sorry about this, but I'm continuing to get this echo, which is, I can hear while I'm speaking. So I can't
Hello,
do this
Armand.
at the moment.
We can't actually hear your echo.
Oh.
One moment.
Well, I can hear it.
Yes, one moment. Sorry. Bear with us. Arman, hello, sorry. Do you have another tab open of yourself with a video behind you?
No, I have no other tab open. I have nothing.
Okay, one moment.
Hello again. Apologies for the technical issues. Hopefully that's now been resolved. So I'll like to share with you our experience, and let me just start the screen share again. Okay, so thank you. So thank you, everybody. I'm a consultant surgeon at the Royal Papworth Hospital in Cambridge. I'm also involved in our national society, the Society for Cardiothoracic Surgery, and the Royal Society of Medicine, and I was past president of our section. Now, I'm going to divide this talk into three parts. I realise it's an international audience, and I will give you 1 minute on Cambridge, 1 minute about my hospital and me, and then I'll talk to you about the topic which I've tried to take an approach of how we've gone from blue sky technology to everyday usage in some areas during the COVID crisis. And I'll also touch on how the COVID crisis has impacted on us, both as a service, but also in terms of how it has impacted on the use of technology. So Cambridge, as you know, is a lovely historic city, and I hope we'll see you visiting at some stage. I work at a place called the Royal Papworth Hospital, which is a new build hospital. We are the country's largest adult heart and lung specialist hospital, and we opened last year, and we were opened by the Queen, but also very importantly, we're part of the Cambridge Biomedical Campus, which is the largest concentration of healthcare resources in Europe, and one of the largest biomedical centres in the world. And so this is my hospital here, and this is AstraZeneca's global headquarters. And right here, in this area here, we are building a heart and lung research institute. Here is the university hospital behind. And then basically what you're seeing here is Cambridge and the surroundings. And this whole area has been described as Silicon Fen for the last 20 years of work in the IT area. And now we're really becoming very biological as well. So it's an exciting place to be. As I said, we opened last year, and we've got lots of patients coming through, and our hospital is being particularly good at being able to handle the COVID crisis because of some of the physical features within the hospital that have helped us. We've got lots of firsts. Probably for patients, the most important thing is we have the best 1-year lung cancer and cardiac surgery survivals, and are one of the country's biggest heart and lung transplant centres. We've had lots of patients with COVID because we're a national ECMO centre, which is extracorporeal membrane oxygenation. And we are lucky enough to be featured every so often in the media. And there's a link there, and you can see some operations done at the Royal Papworth Hospital on iPlayer, BBC iPlayer. And if you're outside of the UK, you'll need a VPN to access that. I've personally been involved with different types of innovations a lot over the years, and this is some novel 3D chest wall technology that I was involved with. And then I've also been involved with low-cost robotic telescope solutions, some surgical solutions, and I will just try and share with you a few seconds of video. If it's not going to do that quickly, so let me just see if it'll run from there. No, okay, let me move on if I can move this presentation on. That seems to be unfortunate. It now seems to be freezing. Well, we've got the spinning ball of moment. Let me just try and come out of this for a moment. Let me just go on from there and ignore that if I can. Yeah, okay, let me ignore that video. Let me tell you, goodness me, lots of mayhem going on. Let me go back to where I was, okay. Okay, so the main body of this talk is going to be about COVID, education, surgical training, and then some lessons with what I think is a warning. And I think the issue about the warning is a very important thing for industries working in this area. So briefly about COVID, we were in a total crisis. If you take us back to February, March, everybody thought they might die. We thought the NHS was going to be overwhelmed. And actually, had it not been for some important government action, we would have been overwhelmed, and that was very important. From the point of view of clinicians, the General Medical Council effectively liberated us. They sent a really important document around which said that we could do things operationally in the field that we thought was sensible, providing the best interests of patients were at the heart of it. And it was recognized that we'd be working in unusual ways. And really what that meant was that we were liberated to use technology without the full process of review that we'd become used to. And that had been a very restrictive thing. Although it was very well intentioned, it did slow down innovation massively. There were terrible concerns about the security of VR technology, about using the internet, about data being routed via international servers. And all of that, as you know, providing you take sensible precautions, your bank codes aren't being released all the time to everybody. And so we realized that we could start to use this stuff very effectively. Of course, there was massive scientific activity. And interestingly, there was the use of cloud AI to do a lot of that scientific activity, which was really important. And I'll touch on that at the end. We discovered new ways of working using commonly used apps. And I'll give you a couple of examples of those in a moment. At Papworth Hospital, we were involved in very rapid review of enormous amounts of literature using AI and using social media platforms to discuss this, and we were able to develop new guidelines within days that would have taken us years in the past. We were able to adopt our own positions regarding PPE, personal protective equipment, and these fed into the later NHS England guidelines. We are very used to dealing with airborne pathogens, so we did what we needed to do. And what that meant was in our hospital, with regard to thoracic surgery, our activity was completely maintained. We actually did slightly more cases than last year, and we had virtually no in-house infections because we knew that we know how to protect ourselves from airborne pathogens. We wear masks, we wear hoods, we're careful, we're clean. And those lessons have been spread more widely. Now, how did that feed into education? Well, excuse me, what's happened to my slides? Okay, right, my slides seem to have vanished and disappeared. Okay, so what I will say to you is that we used, excuse me, let me just, okay, what we did was we switched our education to WhatsApp and Zoom, basically, and Microsoft Teams. And through that, we ran virtual clinics, and I was able to teach medical students from the clinic, and I was able to broadcast my operations in a closed network via Microsoft Teams meetings and Zoom meetings, so that people could view an entirely integrated operating theatre environment. And they were able to visualize my screen, and they were able to visualize my operating, and using, for example, Zoom, they were able to annotate their screens, and I could do that in a reverse direction for online mentoring. And I've got some videos, which probably time now doesn't allow me to show, but my point here, and if I can take you to what the lessons are that we derive from this, is that in the clinical environment and in the university environment and in the healthcare environment, we are very familiar now with cheap or no cost applications, and we can do so much of our teaching with a relatively modestly costed phone or virtual reality headset, and we can bring patients to the students without there being any contact required. And for people, for companies working in this area, I think that the important lesson that I have to share with you, and it's a warning as well, is that your value proposition has to be able to compete with what we can do already using WhatsApp and Zoom. And this is very important because you might have hundreds, you might have thousands of customers who are the end user. You'll have tens of thousands of customers who are the end user. But per head, I think they will pay very, very little. So I don't think that your paying customer is actually going to be the group of end users at all. And so my challenge to you as a practicing clinician is for you to, in your models of the brilliant technology that you're developing, and there are many companies that I'm very, very impressed with. I can mention Fundamental Surgery, Proximy, Medical Realities, Touch Surgery. My challenge to you is who is going to pay for that? And I think it'll probably be industry or the information that you gather from clinicians, doctors, patients' behavior that can guide better decision making and provide value in that. But I don't think that the end doctor or the end patient is going to be the person primarily paying for those services. I'm very sorry about the technology problems that we've had. I'm very grateful for the opportunity to speak with you. And I know that Matt Morgan, who's going to speak after me, is going to talk to you more about VR technologies. And I hope his technical aspects of his presentation go much better. Well, thank you for having me.
And thank you so much. That was great. Despite the issues, it went well. Thank you very much for your time. Is there anything that you would like to tell the audience? Anything you would like them to know?
Beyond what I've said, we are one of. I have an innovation group, and this is a group of students, and I love the energy that these young people have, and we. It's how I run my tutorials, and we, in the process of that, lots of new ideas emerge, and what we're now working on is a 3 or a 4 channel display of operations which are all synchronized, so that people can see on a screen what is happening. At the same time, they can see what I'm doing with my hands, and they can also see the imaging and the operating room environment. And we are doing that using a combination of Zoom and GoPro. So there is a challenge in that for my colleagues who are working in industry and entrepreneurial colleagues of how do you compete with something that can be delivered through those platforms. And I know you'll find a solution. You always do. And I look forward to working with you guys on that. That's absolutely fantastic. You know, we would love to work with you all. We look at new technology every week in our innovation group, and some great projects and collaborations come out of that. So really, that's my take-home message. Contact me on LinkedIn. It'll be great to talk with more of you. Thank you.
Amazing. Thank you so much, Armin, for that. Matt, if we could go on to you, please?
Yeah, hi. So I'm Matt Morgan from the Original Content Company, and Armin, we definitely need to talk after this because I'm just going to show you something now that is related. So very much so. So I'm just going to share my screen now, and I'm going to talk about a project that we did that was funded by Vodafone. So yes, they've been fantastic, Vodafone, on this project. It's a concept that we conceived with some collective of other companies. So Gamula, Explore, the Grid Factory, and we put it to Vodafone, and so I'll show you what it is. Oh. Okay, so as you were just discussing, yeah, there is challenges about education and having the same level of education, medical education. Some students don't have the same facilities around the world. So what we thought was to democratize this and use VR to do this. So the facilities, you could be restricted getting to the facilities, but VR, we can transport people to locations globally, wherever. And traditionally, students would learn with CAT scans and MRI scans, which just are two-dimensional slices of data. And they also learn with cadavers, which obviously they're hard to get hold of and do not react in the same way as a live patient. So what our solution was to recreate this in 3D. So using CGI, we would create a human body with the opportunity for the lecturer to go inside the body. These are the areas that we were covering. So using VR to breathe more life in the classroom. Real-time data, so we can feed real-time data into the VR experience as the lecturer is going through their lecture. The 5G network, so this was very important. So the 5G network, what we created, it was Ericsson, it was Vodafone with partnering with Ericsson, who put a standalone 5G network into Coventry University. They've got a new medical facility there called the Angela Jingle Building, and it's got all the latest tech, and now they've got a standalone 5G network. And we see the education, so VR learning, that someone in a VR headset for 30 minutes is up to 4 times, will be more focused in the actual content that they're receiving. Yes, and this so 2 hours in the classroom is equivalent to like 30 minutes in the VR experience. So how does it work? What we were able to do was a lecturer would be in the VR headset. They would be presented with the 3D body and be able to interact with that 3D body. And from that, we would then stream what the lecturer was seeing in real time over a 5G network up to the cloud, and then the students would be able to receive this on either on their phones, their tablets, their laptops. So it wasn't like model dependent, because a lot of the hard work, the hard lifting of the processing was actually done up on the cloud. And what we used was it's a platform. It was the first global commercial use of NVIDIA's Cloud XR platform that helped make this a reality for us. So this is what we created. It's the body, with like the various sections of.
Matt, you're not actually broadcasting at the moment, your screen. Can you share your screen?
Yeah, is it not broadcast?
No, it hasn't broadcast at all. I didn't realise you'd switched to it. I just realised at the moment you seem to need to share it. Yeah, okay, you're sharing it now, but it hasn't expanded. It's just, yeah, so we can see one which says Storyboard 01. Yeah, that's it. Okay, thank you.
Okay. Sorry, so I'll just quickly just go flick through the slides again. So the challenge with students and the solution. So using XR as the solution. The main areas, the VR, real-time data, the 5G network, and the education. This is the data about VR education. So 30 minutes in a VR headset against 2 hours in a classroom, that the students are more focused when they're receiving the content. And this is how the lecturer, so the lecturer is in the VR headset, and then we're streaming it out over 5G network to the students' mobile devices, so laptops, tablets. And then, yeah, this is the visualization of it. So the human body as you see it, and then the interactive touch points, which will give you more information as you go through it. I'm just going to share a video with you. So this is it in action. Oh. So the lecturer is able to, this is a vascular system. They're able to stop, pause, interact. They can see the macrophiles, the B cell, the T cells, the neutrophils. And so this is all in real time, and it's using soft body physics. So we wouldn't have been able to get this fidelity without the 5G network. And yeah, these are in conclusion. So what the 5G enables us to do with creating richer media with lower bandwidth and a wider connectivity for us and a higher bandwidth. These are the main points that we were able to demonstrate, and literally this is just the first part. We've only created the first phase of it, and yeah, we're looking forward to creating the whole library in the next section over the next year for the university. And that's pretty much the end for mine.
Matt, thank you so much. That was incredible. The technology you're offering is amazing in terms of education, and also improving the education system. This seems like a very good way to go. So if you could just explain a little bit more about how this will affect the education system.
So it's the remoteness. We know like about the number of overseas students, or actually in the current climate, students can't get into the universities. So this, creating a platform like this, enables remote learning and the level of to get everyone at the same level as well. Not everyone has got a fantastic facilities like the Papworth or Coventry Uni. And what we can do is we can create digital twins of the actual spaces, and we can make those spaces interactive and have like the surgeons. We're doing like a live video streaming, having different cameras in different positions, so you're able to actually select which camera viewport you're able to see elements from. So yeah, this would help. And also going forward, what we can do is, if a student say their first language is Mandarin, what we're able to do is a student would be able to audio ask a question in Mandarin, and we could do a real-time translation into English, and that text could go straight into the VR, and then the lecturer could answer that question back out, and then it'd come back out into Mandarin, or Spanish or German. So it's breaking down those language barriers as well, when some students might not have the confidence to ask questions in a language that's not their first language. So yeah, that's what we can do going forward, using like AI, conversational AI translation. So yeah.
That's absolutely brilliant, being able to overcome potential communication issues and really increase the confidence of students who are wanting to learn more.
Yeah, absolutely. Yeah, it's all about this is a global education platform that can just be expanded out and out. So yeah, we've literally created one book, which in this massed like a library, which we can fill with really rich content going forward. And as I say, you don't have to have these expensive devices to receive the content, because it's all the heavy lifting of that content creation is being done up on the cloud. So that is also, so you don't have to have like a VR headset or an expensive, the latest like iPhone 12 or the latest tech. You can have these on the and receive this on the lower end phones.
Amazing. So it's also very accessible. Had Kim who said, so you are using some form of natural language processing? Yes.
There's basically it's an NVIDIA. It's called NVIDIA, and it's the Jarvis plugin. And what that is a conversational AI. And what you have to do is it will build up the machine will build up a library of terminology, so medical terminology, and it will keep on growing and growing. The more that you put into it, the more that it'll educate itself on like a conversational AI for that.
Brilliant, amazing. Armin, we have a question for you. So Barry has asked, how do clinicians and hospital managers embed a no going back approach to reducing bureaucracy, rapidly adopting tech innovation more successfully with less barriers? Armin, we can't hear you. Are you on mute? One moment. Armin, we cannot hear you.
Can you hear me?
Yes, we can. Thank you.
Okay, hi. Right. Can I just start off by saying it's a great question? And can I also just compliment Matt? I found that presentation fascinating. I think that 5G on a closed network is a fantastic way of doing this, and it gets over some of the security concerns. And I'd love to have shown you my videos, and to think that could be uploaded using a 5G network and streamed faster, better quality is fantastic. So we must talk more. So going to the question, right? I think you've just hit the nail on the head, because health tech implementation is really challenging. And let me explain to you why that is, because through that, you'll be able to identify how to make the change. There is an enormous amount of inertia in healthcare systems because we are fundamentally risk and cost averse. Okay, we're risk averse because we don't want to do harm to patients, right? It's deeply embedded in the psyche of doctors, nurses, and healthcare managers because we're all on the same journey, we're on the same road. And that is excellent healthcare outcomes. So one is we're risk averse, and secondly, there is the cost issue. Okay, and it varies around the world. Overall, the NHS is incredible value for money. It's not the best, but it's incredible value for money, and we have better outcomes than the States. So let's just end the spend more gets better results issue right now. So let me give you an analogy. If you go into a conventional shop, if you went into John Lewis and you went to the catering section, the kitchen section, and you saw on the wall 20 different types of toaster, and you think to yourself, do I need a new toaster? And you've got one at home already. And you've got one which cost you £10, which you bought when you were a student and you've still got it. Whatever the new technology is, it has to provide a significant advantage over what you're already doing in order for you to shift off the inertial gravity of where you are. So it's got to make things easier, cheaper, or more cost effective, or improve quality. Now, if it does those three things, it will work. You then need to know who your customer is, okay? The end user, the surgeon holding the knife, you would think they're the end user, but they're not. My surgical blade is changed without any reference to me at all. It's a purchasing decision. So you need to get the silos in alignment. You need to get the different services in alignment. So if you've got some great technology, what I would say to you is go and talk to some clinicians and go and talk to some health managers and get them on the same page. Because otherwise you're going to be stuck with, more often than not, great technology trying to find its place. Okay? And I've seen wonderful companies, brilliant ideas. It does this, but yes, it doesn't actually make anything easier or better or faster or cheaper. And actually, your machine vision would be far better off looking for defects in a space rocket than looking at how a patient's arm moves, for example. So it's about finding the right application for your brilliant technology. So that's the short answer. I can give you the long answer in a university lecture.
Amazing. Thank you, Armin. And yes, anyone who is watching this stream, please keep in mind collaborating. As Armin just really pointed out, we really need collaboration to be able to push this forward, to help healthcare progress. Matt, hello, thank you. Thank you very much for your presentation. Do you have anything you would like to comment on or anything you would like to point out to the audience?
Yeah, no, just following about collaboration because I'm not a medical person, so I know how to make VR. I know how to do that production side, and so this is why I need someone like Aman to give me that education on that side of what they're actually requesting, what their actual need is. So I need to know what their need is, and then I can come up, help with the solution. Because yeah, I could talk till I'm blue in the face all about VR and like low polygons and 3D modeling and streaming and things like that, but unless it has a directed use and the directed need, then yeah, it's just making tech for tech's sake and not for a purpose.
Well, I agree with you so much. I mean, it would be absolutely fantastic to collaborate. I think there is unlimited content out there, but it's about curating it and delivering it in bite-sized packages that can produce change. I mean, I really want to. I mean, I don't know if you've got time for 30 seconds of video, but you'll see what the problem is that we're trying to solve. Shall I do that?
Yeah.
Okay. So let me put it up, and let me just I just have to change screens, so just bear with me for a moment. Okay, so this is what I'm going to show you is an intraoperative Zoom feed through a closed network. I keep saying closed network because it's really important we don't just broadcast publicly for confidentiality reasons, even though there's no identifiable information. But I'm saying that for probity reasons. So let me just share my screen. Okay, so what you should be seeing now is I'm going to expand this. This is a video feed, and I'm just going to start it now. But before I start it, what I'm going to show you is that there's a 4K monitor up here towards the top right-hand side, and this is a small hole through which we're doing the operation, and we've actually positioned the camera through a ½ centimeter hole around here. And just up at the top over here, you can see the imaging. And what we want to do is we want to put all of these at high quality onto one screen, and that's what we're working towards with a 3 or a 4-channel feed. And what you're seeing now is effectively part of the 360 camera view that is almost from the surgeon's position, and it will move around in a moment. But essentially, you're seeing that's me with my protective headwear on, and what we need to show is the hand movements around this hole and what is being achieved when we're doing this surgical dissection, and what the other people in the operating room are doing at those times. So we haven't moved it over, but on the right hand side there'll be the anaesthetist, and they'll be doing things. Opposite me is the surgical nurse, and I'm dissecting out some structures within the chest here, and using different instruments to do that. So those are a pair of scissors going in, and you'll see me sort of going around some other instruments. I'm sorry, I didn't know that it finished with that. But that's the problem. And of course, that should be narrated, and we can give people feedback. Let me go back to the...
Okay, could I just share something with you?
Yeah, sure.
So this is what I'm also working on. Let me just share my screen. So this is a solution that I've put together. It's actually for a theatre, but it could translate into medical. So what I've created is, so this is filming into Teams, and we can either use 360 cameras or just straight cameras. And what you've got here is like the live edit up here, and then the audience will have the ability to click camera 1, camera 2, camera 3. And then actually this is this is to do with the audience actually being put into a virtual theatre and live streamed back into the theatre, so they can actually have a sense of virtual presence. So this is us streaming ourselves back in while we watch it. But this element here, so we literally had, we've got 3 audiences, one in VR headsets, one in Microsoft Teams, and then the other one on 360 video. But this I'm doing this for theatre performance, but it could so easily just translate into what you're talking about.
Well, I think that's fascinating. I really do, and I think one of the things that's really interesting is for education environments, for the person delivering the content to get feedback and engagement. Now, again, here there's a governance and there's a professionalism issue, and that is we do not want a surgeon to be distracted by the audience during an operation. We don't want that for obvious reasons, but also we don't want to be seen for that to happen. But it doesn't. It's absolutely fine for a moderator to be doing things in a safe way. And I think it's really useful for the audience to engage with each other, because we've made fantastic strides in the last 9 months in terms of virtual engagement. And really, I think I'm just having a conversation with you while I'm looking at this, and Jerry's there, facilitating. It's fantastic. But I'd love to be able to see the audience, and I'd like to see who's bored at the back, who's looking at their phone. Stop it, all of you.
Exactly. That's exactly what we've created, why we're creating. So I could grab you out of your video feed now and knock out your background and put you in a lecture theatre. And so you can see who's like not paying attention or who's not engaged with the subject. And then you could give direct feedback to that person. And yeah, it's a sense of connection to the actual audience. So that's what I'm trying to achieve.
Well, let's try and put it together. I mean, it would be fantastic. We can start off with a small group and then, expand it out into, well...
We've already made the prototype. We've
fantastic.
already made a prototype.
Fantastic. So... Well, if we can help, and collaboratively, in terms of prototyping and getting it moving forward, that'll be fantastic.
Yeah, great.
We have a message from Kim. Kim, hello. Can you? She says, can you talk a little bit more about the 5G impact?
Yeah. So the 5G. So over the next year or so, you're just going to hear a lot about 5G and what the capabilities of what 5G can do with the Internet of Things. Like Aman, I could set it up so that using 5G, someone could do remote surgery with robotics. There's this possibility. It's all about the speed and the lack of latency, the low latency that this is achieved, and also the real-time interaction as well. So none of that delaying. This is what 5G is about. So 4G that's okay for like the web for websites and yeah, just 2D visuals. But now we're moving more into this immersion, this 3D element and robotics, and so this is what 5G is just going to open up the floodgates for a lot more innovation along those lines across AR, VR, mixed reality. Yeah, that's what 5G is going to enable.
Amazing, thank you. We actually have Kim. Hello, Kim. Can you hear us online with us right now as well? Hello, Kim. Hello, Kim. Oh, your Wi-Fi connection seems to be a little...
I think she needs 5G.
Exactly, you can provide that to her. Kim, hello. Kim, I think we're having a bit of a internet connection issue. Could you try to speak again, please?
This is a perfect case and example. Do you know, if the 5G networks were all up and running now, then yeah, we wouldn't have this difficulty.
Definitely. And with 2020, we all need 5G to get through our Zoom. One moment, we'll be in contact with Kim. So is there any anything else you would like to discuss, Armin and Matt?
There's nothing more that I have time for. Unfortunately, I've got to go to another meeting. But thank you so much. And Matt, tell me, how do I get in touch with you?
I'll send you a contact request.
Fantastic.
On LinkedIn. So yeah, it's just Matt Morgan and on LinkedIn. But I'll send you one. And also go to my website, which is TOCC, which is TOCC.work, and contact me through there.
Okay, fantastic. Thank you. Thank you very much, Jerry, as well.
Thank you so much for joining us. And as you guys are speaking to each other, it's all about collaboration. So I'm so glad that you guys are getting that together. Thank you so much for joining us this year.
Okay, thank you very much.
Bye-bye. Thank you very much.
Bye.
Three, 2, 1. Hello, everyone, and welcome back to those of you who joined our amazing panel discussions yesterday. And if you're joining for the first time today, we are so excited to welcome you to What Women Want, the Renaissance of Women's Health, our annual event. We are Queer Partners, an advisory group passionate about health tech, women's health innovation. And we're a team of scientists, lawyers, strategists with decades of experience solving your business needs from concept to exit, covering intellectual property, GDPR, regulatory compliance, and commercialization. We work with startups, biotech, pharma, and investors. And we really created this event to share insights and have the most important conversation about women's health, and primarily to build an ecosystem that supports women's health innovation, discovery, partnership, and growth. Today's conversations will be focused on finding solutions to improve women's health, and there will be a live Q&A at the end of the panel, so please use the chat box to share your questions with us throughout. This panel today is titled Year in Review, Breakthroughs and Challenges, and we'll be focusing on COVID-19 and its effects on women, gender inequalities and systemic bias in healthcare, and then our overall learnings this year, how they will advance women's health and what's still not being addressed. And now I'm so excited to introduce you to our esteemed and established panel of OBGYN doctors, who also happen to be entrepreneurs, changing the women's health paradigm, and they're ranging from Canada, the US, the UK, and France. So panelists, when I introduce you, just please give a little wave so the audience knows who's who. Starting with Dr. Jane Van Dies, Medical Director, at Maven Clinic, which is the US's largest telehealth platform for women and family health. She's also co-founder of Equity Quotient, a consultancy providing equity and analytics for healthcare. She's a founding member of Time Ups Healthcare, co-founded OB Best Practice, an online resource for OBGYNs, and she co-admins the nonprofit OB Mum Group, an almost 5,000 person OBGYN Facebook group. Next up, we have Dr. Brooke Vandermolen. Brooke, give a wave. Brooke is co-founder of the OBGYN Mum educational platform, where she shares meaningful insights and advice on pregnancy, fertility, menopause, and so much more. And she shares that with over 60,000 followers, which also is a growing audience. She aims to empower women and to feel in control of their health throughout their lives by imparting knowledge in a relatable way and myth-busting common taboos. Brooke is a co-founder of the Birth Collective, which provides expert-driven, evidence-based antenatal and postnatal classes for pregnancy and beyond. Our third panelist today is Dr. Dan Nayot. Hi, Dan. Co-founder and medical director of Future Fertility, an innovative Canadian medtech startup that applies AI to the field of reproductive medicine. Dan is also medical director of the Fertility Partner, Canada's largest IVF network, and co-founder of Halo Health, a non-profit for angel investing network of entrepreneurial doctors. In addition to that, he also has a degree in maths from the University of Toronto and a master's in clinical epidemiology from Harvard. And last but not least, Dr. Benjamin Vialis de Lesegno is Chief Medical Officer and co-founder of Cellen, a company supporting patients living with chronic pain through a wide array of services. Ben has practiced as an OBGYN in the most remote places by his humanitarian work, from Syrian refugee camps, the slums of India, to Calais with migrant populations ranging from Africa, the Middle East, and Southeast Asia. And now I'm going to hand over to Dr. Marla Mawkin, our amazing moderator for this session. And Marla is the host of the Royal Society of Medicine's Digital Health podcast series. She's also been featured as Forbes 30 Under 30 and in Vogue Britain, the top 10 rising female stars reimagining our future. Marla, the floor is yours.
Thank you so much, and welcome everyone to the Year in Review. Breakthroughs and challenges is what we're going to be discussing today, and it's all part of the Giant and Koya's What Women Want series. So I'm delighted. We've heard already how the fantastic panel have got so much experience that we're really looking forward to sharing with you today. And we're going to be touching on on three main topics, but I'm sure we'll get into a lot more. What has COVID-19 done, and how has it affected the healthcare of women and the technologies and advances that we've had in the space? What about the systemic biases that we've seen this year that have been really highlighted? And then the third thing we're going to be talking about is how we can take these learnings and really utilize it for next year and years to come. I think the first thing we should do is really wind this back and start the discussion by thinking a tiny bit early 2020, pre-COVID lens on. I wonder, Ben, if you can kind of give us a bit of a picture what we were coming into 2020 thinking for women's health, and then perhaps how that kind of changed as the year went on.
Thank you very much, Mala. Thank you, Koya Partners, for inviting me, and thank you everyone for being here. So as Mala said, I had a conversation with Mala one day, and I talked about the fact that 2020 is going to be the year of woman. It has to be the year of woman. If we look at all the grand movements that have been started around the world, this year is the 25th year anniversary of the Beijing Declaration, which was adopted during the 4th World Conference of Women, and where 190 countries determines to advance the goal of equality, development, and peace for all women everywhere. This is a major event. So when you walk in those steps, you're like, wow, 2020 has to be the year of women. And then you look even more and you realize that it's also the 20th anniversary of the landmark UN Security Council resolution on women, peace, and security, which reaffirms the important role of women in the prevention, resolution, and post-conflict reconstruction in countries of war. And then you realize that it's also the 10-year anniversary of the establishment of the UN Women Branch. And finally, the 5th year anniversary of the WHO Sustainable Development Goal on health and gender equality. So really, 2020 could only be the year of women. Sadly, COVID arrived, and now it's mainly the year of COVID.
Exactly. And that is so well put. Thank you so much for kind of giving us that background there. And I think that what's going to be fascinating today is learning how different countries, different healthcare systems have all adapted to the change. And I really want to take it to you, Jane, if at all possible, to kind of kick off as someone that leads healthcare provision services and service development. I wonder if you can kind of depict for us how the year looked for you.
Yeah. So, I mean, we as a company were really created to help fill gaps in care. And as my fellow OBGYN on the panel knows, there are a lot of gaps for women's health, and especially around preconception, even pregnancy itself, and really markedly in the postpartum period. So that was really some of the genesis of Maven's creation back in 2015, was to try and fill gaps in care, but also to bring practitioners to women in their journeys, whether fertility, pre-pregnancy, pregnancy, postpartum, or parenting, that they might not have access to in their community. So to that end, providing telehealth visits with lactation consultants or occupational pediatric physical therapists, a lot of mental health specialists in infertility and perinatal care as well. And so we really came into 2020 still trying to figure out how to reach women, how to let them know that services that they might not even have been aware of, could be available on a digital health platform. And then what we saw initially was a real market uptick in mental health provider use on our platform. So we saw in April and May a 300% increase in mental health utilization. And I think throughout, obviously, around the world, people are looking for valid, scientifically evidence-based information, not only obviously about COVID, but how COVID might be changing their course. They might have put fertility plans on hold. They might have unique questions about COVID vaccine and breastfeeding. I just got one of those questions today on our Instagram Live. So I think being able to be a place where women and families knew they could come, both for information, but also for personalized telehealth visits with practitioners who absolutely understood, you know, where they were at in their journey and really tried to help facilitate. So I feel like it's been a lot of learning on our part, but also a real appreciation for the availability of mental health practitioners throughout this pandemic.
Thank you so much for that. I wonder if we could speak to Brooke next, because something that you touched on, Jane, was about the questions that people have throughout this. And I know, Brooke, throughout your community, you're talking with them and interacting with, as we heard before, upwards of 60,000 people at one time. And I wonder if you've seen throughout COVID a change in the questions that people have had, and if you could share that with us as well, that'd be lovely. Hello.
She might be on mute.
Brooke, I think your sound is on mute.
Oh no.
No.
Oh, okay. Well, we'll come back to that. Well, hopefully, Brooke,
Can you hear me?
Okay. Yes, I hear you.
Okay, yeah. So first of all, I just wanted to say thank you once again to Koya for having me on. And I guess from the many hats I do wear at the moment, one of the hats is through speaking to women in my Instagram community, and that's where a lot of my followers are. Most of the people that follow me, I speak a lot about women's health problems, a lot about pregnancy, fertility, breastfeeding, and those sorts of issues. And so I have seen a huge change in the type of questions that I was getting, especially, you know, around March, April time. There was a lot of uncertainty, of course, and isolation. Those were the two key themes that were coming through to me really strongly. I was absolutely inundated at the start with questions, obviously, about how coronavirus could affect you if you are pregnant, people who were undergoing fertility treatment or just about to undergo fertility treatment, who had all of their treatments put on hold with no idea on whether they would be able to have them again, especially if you're kind of age 40 and coming up to the time in your life, you know, where your chances are rapidly decreasing and you've suddenly been told indefinitely we're putting everything on hold. That was really the uncertainty, and then people just feeling like they had nowhere to turn, nowhere to get the answers from. Doctors were closed or were people hadn't really moved well online at the start, and so there was just this feeling of, you know, what do we do now, what's happening? And I think, as obviously the pandemic's evolved, I think people have received the information. A lot more of the information has got through to people. Obviously fertility treatments and things like that have started up again. I think in maternity we have moved very quickly and quite well. I think I'm in the UK and in the NHS we've moved partly into back to face-to-face appointments, but also more and more kind of telehealth as well than we ever did before. So we are getting messages across and seeing people and reducing some of that uncertainty. But there have been other challenges as well that I'm hearing about. For a lot of women who are working, they became the primary caregivers. And, you know, every family setup is different, but a lot of families that ends up being kind of the women who may be working but suddenly had the children at home and was trying to balance things like work with looking after children and trying to impress at work and really struggling with that kind of whole balance. And I think people were feeling really that struggle, that mental health burden, the guilt. A lot of mothers that I speak to kind of similar to me and have young children, who've recently been pregnant, maybe just gone back to work from maternity leave and really struggling with that balance. So those were some of the key themes that I had. And I think just generally healthcare challenges. We are struggling with that balance of how much should we go and seek help for our problems if you've got what's seemingly benign problem like heavy periods or incontinence that's really not really bothering you that much, but then do you want to be coming and going from a hospital at the moment? Do you want to wait until after the vaccine? And these kind of questions people still really don't know the answers to. We don't know the answers to as medical professionals as well, how to advise people and how much, you know, we're still playing catch up massively with all of the things that went on hold, especially in our first lockdown, trying to get through the cancer treatments and the urgent treatments. And so when are we ever going to get to dealing with the problems that are real problems that women face on a day-to-day basis and they're just at home struggling and waiting? So yeah, that was a bit of a summary of a lot of.
No, it's fantastic. Thank you so much. And I mean, really clearly dictated some of the problems that we've seen and we've heard about over the year in a really lovely summary. So thank you. I want to take it to Dan now. Dan, we've heard a lot over the course so far about fertility, things going on hold. You're particularly focused on innovation within this space, and I wonder whether or not you could kind of talk us through some of the things that you have found that we've been able to. I want some good news stories here, Dan. Like, what have we been able to do despite of COVID for fertility this year?
Well, I think I echo everyone's comments. At the beginning, when COVID started, it was, panic and fear, specifically in our subfield in fertility. We were scared that it reminded us of this Zika virus that was hot news a few years ago, and we didn't know if we were going to tell people that, like, hey, abstain till we have more information. Stop your fertility treatment ASAP. And us as physicians, we were trying to gather data so we can have something to tell people. I think it's very, the second thing that happened is that the clinic sort of closed for a few months. I'm not saying all clinics, but a lot of the big national groups sort of advised the clinics to close. And that was the fear of, will it ever restart? The impact of age on success and things like that. The third thing that happened is the impact of infrastructure. So a lot of times when we closed for a few months, everybody needed to have an income somewhere. So we lost support staff and nurses and embryologists. So when we came back, we weren't at full capacity. But the good news story is what has happened because of COVID. I think it's not specific to fertility, but we've essentially accelerated where we thought we were going to go. I was in my practice, sometimes patients would drive 4 hours to just have a conversation with me or to sign a consent form, which is totally a waste of their time. I mean, I didn't mind. I was sitting in my office waiting for the next person to come in. So the whole digital platform, just the acceptance, from all physicians to do that as a way to communicate. But then you see all these really innovative medtech software platform add-ons that we can make things faster, like signing consent forms, sharing screens, educating modules, and things like that. So I think it's just accelerating the space, that the more these small startup innovators find customers and success stories, the more we're sort of focusing more on the other solutions that are out there.
Thank you so much for sharing that. That's really interesting. Ben, I want to ask you one question before we move on to talking a bit more about the systemic bias that we've seen throughout this year and that's been highlighted. And that is, you've worked in labour wards throughout the world, and you've worked in labour wards in the UK during the pandemic and on humanitarian missions, whereas we've heard earlier, it's been in war-torn countries and places where people are giving birth in the most extraordinary of circumstances. Could you talk us through, I mean, with, as Brooke says really clearly, the uncertainty and isolation that mothers are facing, or soon to be mothers, what was happening on the labour wards within the UK and globally, and I mean, and how did that actually change the experience of mothers?
So I think it's a really interesting question. I will say that, happily enough, the state of the change in the reactivity and the change in the capacity to support patients that has happened in the UK is absolutely not as important as the ones that I've seen in Syria and India or anywhere else, gladly. But definitely we have seen an enormous difference in our capacity as healthcare providers to be able to support patients. And as Brooke said, it's also because for a long time, we just didn't know what to tell patients. So in my department, what happened is we had certain beds that were reserved for patients where we didn't know the status, certain beds that were reserved for patients where we knew that they were negative, and certain beds that were reserved for patients where we knew that they were positive. But it takes a lot of time to train the hundreds or 150 midwives that are going to go and take care of every patient, making sure that everyone understands very precisely the rules. So you always end up with a certain amount of doubt within the healthcare provider community, which is transmitted and which is actually amplified at the level of the patients. Because when a patient asks a question, they expect you to know, because you are the doctor, you are the midwife. And if you tell them, well, actually, I don't really know, let me go check, I'll come back in a minute, it's not always what they want to hear. And that has led to an enormous amount of anxiety, an enormous amount of loss of the French word is coming, repère. A loss of control on the side of the patients, loss of control on the side of the healthcare providers, and it has led to enormous amount of anxiety, as I've just said.
Can I also jump in there and say, I think over the last many years, we've made great inroads in kind of moving away from patriarchal medicine, where we are doctors tell patients what to do, and we're empowering women, and we're telling them, if you want to hypnobirth, then you can have water birth, and if things you can kind of take control of your own pregnancy. And actually, I think in COVID, we've almost switched back. People don't know what to do. They don't know, and they're now waiting for doctors to tell them what we can and can't do. And at the start of COVID, we were saying things like, you can't have a water birth, you can't have a home birth, you can't have, because we just didn't know. And that again made people feel more traumatized by their birth experience, giving birth on their own because they were told you can't have your partner. And again, hopefully now we're moving out of that as we understand more about what is safe and what isn't. But I think there was a very negative impact on labour wards in those kind of conversations, where we just kind of had to implement more rules until we knew more about what is safe and what isn't.
How fascinating. Going backwards almost in time to be able to go forwards, right? But you've heard it first at the Giant Health Innovation Conference. We're talking about how we had to go backwards, right? But it's fascinating. And I think, Jane, I want to move it now, because I know we've got a lot to cover as well. And I want to discuss your fantastic work in understanding the inequalities that women face and being able to tailor a service towards them, and something that we've been really passionately discussing in 2020 specifically. Could you talk us through how we can target services to really personalize it for women?
Yeah, this is one of my favorite topics. It's inclusion has been a core value at Maven since we started. I feel like a lot of how we built our fertility journey was very inclusive, has always been very inclusive of, for instance, LGBTQ parents. To that end, we definitely have, adoption experts, surrogacy experts, as well as fertility and mental health experts who are well-versed in caring for LGBTQ couples that are on a parenting journey. So whether that's trying to adopt or find a surrogate, and then also connecting with in-person clinics here in the US that we know to be LGBTQ friendly. So that's always been a core mission of ours. And something that we've been thinking about in the last 6 to 7 months is how can we make sure that when clients and patients come to our platform, that we are able to care match them with people that they want to see. So, for instance, a lot of women, to Brooke's point, have had experiences of either trauma or discrimination within the healthcare system due to it being based on a white patriarchy. And so the idea that we have and the model we'd like to roll out is basically a care matching model. So if you would like to see someone who has the same race, ethnicity, language, geographic background, in order to create psychological safety within the healthcare setting, we want to be able to do that. Obviously, that means we have to collect some demographics, and I'll be honest with you, sometimes collecting the demographic information can feel like a privacy incursion. So it's a delicate balance between finding out what members' needs are, being able to match them with a practitioner who can meet them where they are and with what they need, without feeling like we're asking too many private questions. I think this is probably a challenge for a lot of digital health companies in that way. But I'm really excited. You know, diversity and inclusion is also not about just the care that we provide. It's also about the values that we hold as a company. And so I can say from within that, you know, we have diversity target goals, and we've been meeting them and really trying to walk the talk that we put out there. And so it's been a year, I think, of radical change, but also radical reflection as well.
I think that's just brilliant, isn't it? I feel like all I've been doing this episode of Giant Health is just saying how wonderful and fascinating and brilliant this discussion is. But it is, I mean, it's so inspiring to be around you guys. And Dan, I'm going to put it all on you now to follow on from Jane. But I wonder if you could tell us, your family in the innovation space, and you're looking at the new things that are coming through. I keep asking you the future of things, but please tell me more promising news, Dan. Are we creating solutions that are looking after these big problems that we've got at hand about inclusion in women's health?
I mean, we're certainly trying to do that from different ways. One, just either, I'm just talking from a med tech startup, like either investing in these sort of, I don't know if they're niche, but it's sort of these equalizing platforms or founders from, you know, a diverse profile. I thought Jane's comments were great. I thought matching people is an excellent idea just for cultural sensitivity, same language, you know, probably helps with attrition. You know, race in the fertility world, like race is so complicated, right? Like, you know, the obvious things are like access to care. Like, do you even have a family doctor to refer you? Do you even know where to go? Can you afford these treatments? But I think one theme we're seeing that's sort of like, I guess, moving the bottom floor up is, you know, kind of things like what Brooke's doing, just like educating people. You know, sometimes not everybody gets the same sex ed class going through school of contraception and the reverse of contraception of like trying to conceive. I think that, you know, I think probably social media platforms somewhat have even the field, but just patient education is a key part. So people know you know, sometimes we think the common message is common, but not everybody gets that message. So I think that really is helping people advocate for themselves.
I mean, that leads us nicely into Brooke there. Brooke, how is education making big footprints here and moving the conversation forward in inclusion?
Yeah, I think, thank you so much for those kind words. And absolutely, I totally agree that it plays a huge role. We need to listen as well as talk, but I think having these conversations in a public domain, I mean, I can hold my hands up and say I kind of didn't really openly discuss these issues before 2020. It's definitely been kind of a real positive of 2020 for me, because I just felt like, well, what's my voice going to add? But I realize now that the purpose of me having these conversations in this kind of environment is to educate and also to listen, because us healthcare providers for so long haven't really been listening, and we maybe thought, well, this isn't really our problem. But now, you know, in the UK, and the Embrace report that we had said that, you know, Black women are 5 times more likely to die in childbirth. We need to listen, and we need to take note of that. We need to ask why, and we need to look at that. And there have been some great things have come out of the campaigns around this figure. There's a great group called 5 Times More who are campaigning around this. And one of the things that they're doing is they are providing Black women specifically with a toolkit to empower themselves again. So because we are having these discussions, we're encouraging people to ask the questions. And so if you are feeling that you aren't listened to, if you are feeling scared because you think you're going to be part of a statistic, you can ask those questions. You can use your voice, and you can also empower your birth partners and the people around you to say, you know, if I'm saying I'm in pain, and don't let somebody fob me off. And if I'm not happy, I am going to seek a second opinion. And actually, yeah, people might know that they could ask to see somebody else, but actually, if you're told, no, you need to speak up for yourself, and you need to, until we fix all the rest of the problems in healthcare, I can at least give you that confidence that you can keep asking and keep going back until you're listened to properly. Now, as healthcare providers, we've got a lot more than that to do. But I feel that one thing we can do through education, through social media, is at least in the interim helping in that gap.
If I could just, if I could double up on what Brooke said, you know, I read an article in the New England Journal not too long ago about what just healthcare looks like. What does it mean to have a just healthcare system? And something that I'm actually going to be writing about this week is the role that shared decision-making plays in medical encounters, for instance. And I think, you know, Brooke has said so eloquently how important it is to have conversations that flatten the hierarchy. You can still be the medical expert, but you can engage in your listening skills to make sure that decisions that are made in a shared decision-making model and for a just purpose. So, I mean, I wish that all of us who have graduated from medical school could maybe go back and do some learning on this. So people will have to opt into the learning. But I think that it has to be a core value of medicine that that we engage in shared decision-making, making sure that the model that we are imagining, whether it's the start of magnesium for a preeclamptic patient or the recommendation for a cesarean due to a labor progress that isn't advancing, you know, there are ways to engage the patient in order to make sure that they feel heard, listened to, and that is a shared decision-making model.
Thank you, Jane. And I wonder, Ben, if you want to pick that up about the shared decision making specifically. I know that you are very passionate about personalized care, and I wonder if you could talk to us about how you use the tool of listening to create services that can be as personalized to each patient as possible.
Thank you very much, Mala. I love what Jane said. I think it's absolutely true. Shared decision-making is at the center of the new era of medicine. And it's something that I've seen everywhere. It's something that I've had so many places where I've seen patients come to me and ask not to be told when we were in very difficult situations, because that's the framework that was imposed upon them from birth. I've seen that in Syria, for example. I have this example of a father coming to me and talking to me and being like, oh, no, you can't tell her that. I'm like, well, I have to, because it's not, I understand that there's a cultural difference, and I understand that you feel that it shouldn't be told, because it was a complicated labor, and it was intermittent listening, and sadly, at that point, we were not certain that the baby would survive labor. And I'm like, we need to take the decision. There's no cesarean-section option. There's nothing we can do. We need to do a vaginal delivery, and we need to take complicated decision at the moment. And this husband was telling me, no, you can't ask her. we need to make the decision, you and I. And I had to explain. And once the discussion was started with this patient, you realize that she was actually thankful to understand. And you go beyond the cultural expression of consent, and you reach into that person's personal life, and you realize that it actually made a difference, even though she was not expecting to be involved in the decision, and her husband was not expecting that I would ask her. So that's one point. And I think this kind of experience I brought back to my practice in the UK. I brought back to my experience when I work in our health tech company, in my health tech company, every day. We're very proud because this month the Levac Clinic, which is the first fully digital patient-centered pain clinic in the UK, is launching, and we have changed the dogma around pain treatment in the UK. Right now, pain treatment is centered on the fact that when you're referred from your GP to a pain unit in the UK, most likely the first person you're going to see is going to be a consultant, and consultants are at the center of the decision making. Whereas actually, if you look at the biopsychosocial model of pain, you need to encompass every facet of the personality of the patient to be able to help them with their chronic pain. And that includes all the horrible things that could have happened to that person, I'm always thinking about gender-based violence, because that's something that we see so much in pelvic pain. And if you are actually designing the care plan around the patient, about patient-centered outcome, if you're providing a care that is including psychology, if you're providing the care that is including physiotherapy, like nurse-led consultations, doctor's consultations, you realize that putting the patient at the center of the care is the most important thing we can do.
Wow, I don't really. I feel like we might as well just call it quits there. We're kind of done, aren't we? Yeah, clap. No, I'm joking. Don't worry, we'll carry on. I think it's fascinating, isn't it? Just hearing all of these stories, and it gives us so much motivation for the year upcoming about all of these lessons that we can take forward and real things that we can do to make impacts on every patient that we see and every patient that we are interacting with. Let's start with Dan. What lessons are you going to be taking through to 2021 that you've learned this year? And yeah, that's it. I'll leave it there.
What new lessons? You mean COVID specific, or just as time goes on and we evolve?
Well, it's the year in review, so if you can do anything around 2020, but I'll take anything.
Yeah, I think one thing I've taken is, a lot of these digitization, what's happened is you've been able to get more data points, or at least measurable data points. And I think with that, I'm a big believer that, like, if you can't measure it, you can't quantify it, you can't improve it. Maybe that's not always true, but and so I think that trend of being able to find, like, let's say a subset of patients who aren't getting serviced or unhappy with service, like, I don't think we had the fingers on our pulse before all of this was digitized. We didn't know, for example, you're seeing, 50 patients a day, and you ask them to follow up, but you're not really keeping track of who's following up and who's not. You're just seeing the next day your next 50 patients, but now you can learn, like, who's not following up and what are you not saying to them, and what piece of the education module. So the insights, the feedback loop, I think, is closing. Like, where we're starting to see patterns, either like why patients aren't happy at a certain clinic, or what we're not providing for them, or why success rates are different, and things like that.
Great. What about you, Brooke? What are you going to be taking through to next year? Oh no, we can't hear you, Brooke.
She's taking through a new computer.
Yes.
Oh no. Come on, Brooke. We got her back before. We can get her back this time. Oh my gosh. How about just shout? Just keep shouting, and then when you come back, we'll go straight to you. In the interim, whilst we wait for Brooke's mic to turn back on, Jane, do you wanna tell us what you're going to be taking through?
Yeah, well, just to circle up on what Dan was saying, we definitely are looking at personalization. Right now, we're putting together a high-risk pregnancy risk stratification program. And what that will allow us to do really is to hopefully impact pregnancies in the beginning, in the first trimester. We know that a lot of pregnancies can be impacted even when women come into pregnancy with pre-existing conditions, like a history of hypertension or type 2 diabetes. Those are probably the two that occur the most in the population, and for which we have the ability to hopefully change some pregnancy trajectories. So it could be as simple as helping women remember to take their baby aspirin if they've been qualified to do so due to high risk. It could be giving them extra time with the nutritionist or diabetic educator. I know, and I know Brooke knows too, that oftentimes when we have gestational diabetics or diabetics in pregnancy, we have enough time built into our schedule to take care of them in their pregnancy, but not always enough time to describe the different carb counts between 8 different types of yogurt, for instance, or what foods to eat at what given points in the day in order to maintain good glucose control. So there are a lot of ways in which a team approach to healthcare, and specifically pregnancy, and very specifically high-risk pregnancies, where a team of experts can really help to move the needle and improve both maternal and fetal outcomes, given that, for instance, women with hypertension and diabetes are at increased risk for stillbirth even. So really trying to develop a personalized experience for our moms who are on a high-risk journey, and really try to help improve their and their baby's outcomes.
So we've got data so far from Dan. We've got risk stratification and adapting a personalized model for the high-risk mums. Brooke, can we hear you yet? Oh, not yet. Not yet. Okay, we'll keep trying. Ben, fingers crossed we can hear from you. What's your 2021?
I think it is leveraging technology for making sure that outcomes are patient-centered. Because when I look at the first impact that COVID has had on healthcare is the fact that, well, telemedicine has exploded. If you look in the UK, in January, only 3% of all GP surgeries were providing consultations online, and now it's 97%. So that's one thing. But transferring care from a physical consultation to a telemedicine platform is not enough. And you need to look at how you can leverage that technology to make sure that you center your care around patients. And at Leva Clinic, what we've done is that rather than focusing on random metrics around pain and being like, okay, so your pelvic pain was at 7, now it's at 6, we're actually centering the care around patient outcome, which is okay, the purpose for the next 3 months of treatment are going to be that now you're going to be able to walk your dog as long as you want and not have to come back after 10 minutes because you know that walking is too painful for you, or being able to be able to pick up your grandchildren. And this is centering around patients and leveraging the capacities of telemedicine to do that is actually going to make a difference.
I love that. I mean, I know we keep giving round of applause to Ben, but everyone deserves a round of applause for this. Yeah. Please, does the microphone of Brooke's work and deserve a round of applause? Brooke? Anything? Oh, you're on mute, so it might actually work if you unmute. Let's see.
I'm going to say that the common thing you're hearing from all the panelists, in my point of view, is that like we're all looking. We're all reassessing an old problem. Like pelvic pain was always felt this way, OB care was always delivered this way, fertility was always, and I think that's the trend you're going to see. Like, sometimes a solution was, sometimes a solution or a system was created 40 years ago and taught to the students, and now I'm their student, and so I don't even remember why it started that way. But when you get to rethink things from the beginning, I think it's going to change things. A good example is what we're working at Future Fertility. When I went through fertility, I just thought it was crazy when I learned that you couldn't assess an egg. There was no valuation system. There was no good egg versus bad egg or scoring system. And it's just an accepted part of our field. And I thought, there's now new technologies, machine learning, AI. Like, let's not just accept it. Let's see if we can, reassess the whole thing.
Love that. Start from scratch a tiny bit and just see what happens.
I think that's the theme you're seeing everywhere. Like, how do we readdress pelvic pain? How do we educate people?
Exactly. And Brooke, starting from scratch with your video, let's. What are you taking through 2021? Tell us.
Everything everybody else said, for sure. I think, on a personal level, I guess one of the things we've already discussed is, the racial impacts of everything that's happened this year, understanding my own implicit biases and how we engage with people on that kind of level. I think I've also learned a lot about technology. We've learned to use technologies, especially in medicine, in a lot of ways. In the NHS, which is quite a slow-moving beast usually, we have understood, obviously, the benefits that technology brings, but also how to integrate them into our regular practice in a way that people, I think, can be quite scared of in bigger organizations when you worry about the impacts. And I think we've seen a lot of positives that a lot of different types of technology can bring, and things like telehealth and the benefits of those kind of things. I mean, I'm thinking also of devices, and we're using blood pressure monitors and encouraging people to track things in an app where previously, like probably a year ago, if you'd have asked a doctor, what do they think of that? They'd have said, oh, well, that's all fine if you just want to keep an eye on it yourself, but we wouldn't use that to rely on. But now we're saying, no, we do want you to have a blood pressure monitor at home. We do want you to tell, us your readings if you've got preeclampsia. We don't want you coming in and out of the hospital all the time. And actually, it's probably worse for your blood pressure. And so I think we have started to integrate technologies ourselves into our regular practice and adapting how we practice medicine. So I think, and like we said earlier, using the data that we can get out of that in a really positive way. So I'm looking forward to seeing what 2021 and beyond brings in those areas.
Lovely. I'm so glad we got to hear from you. Now we're about to move on to some Q&As. I just want to kind of summarize what we've talked about so far. And I suppose it's been fantastic because the purpose of this was to look at the year in review, look at the breakthroughs and challenges. And we have seen the challenges. I mean, we don't need to go through that all over again. And we've seen so many examples of pieces of work and people coming together in a community-based approach to really tackle these challenges head on. And I think there's one thing that we've learned here is that technology has been able to augment our acceleration through this and be able to adapt to the challenges that have been there in front of us, whether that be a whole host of challenges that we've discussed. And I think that something I'm definitely going to take away from this is the power of just you guys working as the professionals on the ground, listening to the patients and really taking the time to hear what they say and adapt that into your practice. I think it gives us a whole host of hope to go forward. So with that, I'm gonna give it back to the choir girls to ask us some questions. Hopefully not too mastermind tough, but thank you so much, guys.
Thank you, Mala.
Thank you very much for that. Thank you. So maybe a question starting with, again, COVID-19. Maybe I'll throw that one at Jane. As a clinic, will you be administering the COVID-19 vaccine to women trying to conceive or who are already pregnant? What's your stance on that at the moment?
Yeah, so we're a digital telehealth company, so we don't have any in-person ability to administer a vaccine, but we'll definitely be sharing out all of the best practices, all of the questions that I'm sure will come up, and be giving advice. I know that during COVID, a lot of our members received Maven through their employers, and a lot of the employers that we work with really ended up relying on Maven for evidence-based information about the pandemic. So I'm hoping that we will serve that advisory and expert role as the vaccine rolls out as well. But we don't have the ability to administer any vaccines ourselves.
Thank you very much. The next question from Laura. What is the role of OBGYNs in terms of recommending products? And do you feel that the OBGYN community is informed enough? So we've talked a lot about educating women, but what about educating OBGYNs? I'll throw that question maybe at Brooke and Dan.
Sorry, would you just repeat that one more time?
Sure. So what do you feel is the role of an OBGYN in terms of recommending new products, new services to women? And do you feel that the OBGYN community is informed enough? So we've talked about informing women. What about informing OBGYNs?
Yeah, I think that's been another really interesting thing that's come out of this year. We are expected to keep up regularly with new guidelines that come out, with new big, important papers that come out. But probably apart from the kind of revalidation cycle that doctors go through on a regular basis, we may not all be up to date in every aspect of practice. I think COVID and the vast amount of information that's been coming out about it in kind of peer-reviewed papers, but papers that then got retracted or got then superseded by another paper. I think a lot of doctors are really feeling it's been testing our understanding of how to read a paper, how to interpret a paper, and how to also communicate with our patients. So it's so important for doctors to stay up to date and also be able to critically appraise new research, new guidelines that come out, because that is our role, absolutely, is obviously to practice the most current evidence-based medicine, but also be able to translate it to the people that we're trying to communicate with. And that can be really difficult because, statistics, risk is really hard to explain to people, to explain to somebody, a risk of death or a risk of your baby, not making it, or preterm delivery. These are complicated discussions to have, especially when you have conflicting information around. And in every single aspect of medicine, there's conflicting information. You can find a paper that pretty much opposes any view you want to put out. So we do have such an important role in communicating that, in educating ourselves on a regular basis and trying to stay up to date. Things aren't normally as fast moving as they have been in terms of coronavirus. You don't normally get papers superseded like the next day or a few days later, as has been happening now, which usually should make it easier to stay up to date.
Yeah, I actually think that was one of the best questions I've heard of the year, because it hit something right on the nail. I'm talking about in the innovation startup space there, I would say there's three spots. There's like direct to consumer. So that's up to the educated consumer to decide if it's right for them. There's obviously a need, the physician or the medical field to, we're thinking like medications or vaccines and stuff like that. But there's a whole bunch of gray where the, let's say OBGYN is like is the gatekeeper, whether it's gatekeeper like, hey, there's another way to treat pelvic pain. Have you tried this? So does the OBGYN even know that exists? Or it's the gatekeeper in the sense that like, what you tell the patient really affects them. Like, I would never try that, or wait 7 years till there's 3 RCTs and things like that. I think it's an amazing, and I think that's why startups, they're always thinking about that, right? So there's these amazing like ideas that they're like, well, if you need the OBGYN to give the clearance, this is just never gonna fly. It's gonna take us 25 years and $500 million. And even though it's a great idea, it's just never going to fly. But you're right. I mean, that's really why we created Halo Health. Halo Health is like an entrepreneurial physician network that like help the startups, but really like spread the word. I mean, I see a lot of neat fertility stuff. And when I share with other fertility physicians, they love it. There's no like website that shares that. It's not in the journals, right? The journals are more scientific. I mean, you'd like to think the startups are also focusing on the scientific validation, but I mean, there isn't a scientific American of cool products in our subfield. I guess there's conferences.
Yeah. Thank you very much. Maybe I'll throw a question at Ben from Nicola. So are you worried about over-prescriptions, misdiagnosis with the new digital health models that we've seen in the last few years coming up on the internet, where you can essentially fill out a form very quickly on the internet and then receive a prescription at home? Are you worried about that type of model?
So it's a really interesting question, Nicola, and thank you. I think there's something to realize is the amount of governance that exists in the UK. So let me tell you a story. There was this online clinic which was functioning under the umbrella of the EU, and that was prescribing morphine for chronic pain to patients. And the UK regulator, called the CQC, did tests on their platform. They realized that once you have answered the questionnaire, the prescription for your morphine was coming into your email less than 0.7 seconds later, which means that actually there was no doctor validating any prescription. This is the kind of, and of course, this clinic was flagged by the UK regulators, and was then and the access to the IP of that online clinic was banned from the UK soil. So you could not access that clinic. So there's actually a very, very good framework and governance in the UK regarding consultations. There's another story that happened in the UK with a clinic from the UK, which is a patient that went online to one clinic to get a vaporizer, an inhaler for his asthma, and then went to his GP for another inhaler for his asthma, and then went to another online clinic for an inhaler for an asthma. And what happened is that that patient ended up in ICU a little bit later, because actually this was a sign that the asthma of that patient was getting worse and worse, and none of the clinics online had connected with the GP to say, oh, by the way, I've just prescribed this. And so there's now regulations online for online clinics such as ours, which is like, okay, you always have to tell when you prescribe a new medication to the GP, because the GP is the gatekeeper of prescriptions. There's other forms of regulations that are saying, if it's a control drug, then you need to go through that hoops and this hoops, and you need to make sure that all of that. So actually, within the UK, consumers and patients are extremely well protected.
Thank you, Benjamin. That was a great answer. Maybe one last question, one or two last questions. Jane, we have a question from Sasha. The question goes like this. So, how are previous generations of doctors and OBGYNs, I'm assuming all of us are relatively young. So how are previous generations of OBGYNs moving to the digital health world? And do you think there are any barriers for them? And how do you engage them? Because you're a digital clinic. How do you engage previous generations of OBGYN?
I feel like you're talking about two separate entities, right? Because I admin 5,000 OBGYNs in our group. 99.5% of them are probably providing in-person care. They might have augmented with telehealth over the pandemic. And maybe some of them will transition to a combination of telehealth and in-person care after the pandemic. But I would say, honestly, the majority of those practitioners are going to go back to full scope practice via in-person care. So really, I'm not sure that the question applies necessarily as much to the practitioners of OBGYN as it does to the patients who are maybe looking for digital health platforms for answers to questions or solutions to problems that they have. I can just say that, Brooke, I'm not sure what your constituents are like, but I can't say that I'm seeing that there will be a digital health revolution among the majority of in-person care providers.
Yeah, I would certainly agree. And I think that the older generation probably do take longer to come on board. We've gone paperless in our hospital. It was a long time coming, spoken about for a long time. And certainly the biggest complaints were coming from the older generation. But that doesn't mean to say they won't move with the times and they can't. But I think it just comes down to what are you used to. If you went through medical school with a laptop and with access to online papers, or if you were of a generation where everything came from physical papers in the library, we're just if you've grown up with it, it's much easier to adapt to these kind of ways of using. But I think everyone I can see is coming on board, possibly a little bit more slowly in certain areas.
It makes me think, Brooke, it makes me think of a discussion I was having with a friend last week, where I said, the first article I've ever wrote, I had to go to the library and pick up every reference with the librarian from a physical booklet of articles. And when I wrote my MD, I think I had around 470 different references in my MD, and I would have never been able to do that by hand inside a library. Impossible.
No, exactly.
Yeah.
Thank you very much, everybody. So we're going to wrap it up. What a fantastic panel. I thank you all for being here today. We hope that the audience from this discussion will have understood a little bit better the impact of COVID-19 on women worldwide, a little bit more about the gender-specific and minority biases in our respective healthcare systems. And hopefully we're ending on a positive note and starting very soon, 2021, with many innovations to come. We've read about testing breast cancer from saliva testing and many other innovations. So there's so many things to look forward to in women's health. So thank you all again, Jane, Brooke, Dan, and Benjamin. And we hope to see you next year for the next Career Partners, What Women Want, the Renaissance of Women's Health. Visit our website and learn a little bit more about IP law with Fish and Richardson, investing with Avestra Ventures and SCT Ventures. Thank you, everyone. Have a nice evening. Thanks for joining.
Thank you, everyone.
Thank you.